I think there must have been a delay in my stream actually showing and the stream actually starting. So I hope you are all welcome and you're all doing very well. And well, this is pretty much, we're going to be looking at Osce stations, and I hope you guys have as much fun revising with this. And those that are writing exams, please pay close attention to this, not just for your end of rotation, but for your final exam. Pay very much close attention to what's going to be discussed here, because you may not necessarily get the exact same stations on your Osce exams. They may variate a bit, but the concept is still going to remain the same. So let's now go into the stream. Some of the questions you may have seen on the YouTube channel, some of them you may not have seen on the YouTube channel. So we'll start with our question 1. If you have any questions, please feel free to type in the chat box. There is a bit of a delay, a lag between me seeing your chat questions and actually what you're going to be seeing on your screen. So please take note of that. So if I move too fast and overlook your question, then I'll come back and have an answer at it. So we begin with our station 1. So this will be quite an extensive thing. So I hope you have your piece of paper and I hope you have your pen. So let's start. So study the picture and answer the following questions. Describe the abnormality. What is the most likely diagnosis? List 3 important features of this condition. Now remember, if you get such a thing, it's either you know it or you don't. Either you have seen it or you haven't. So whenever you see something that's shaped like this almost looks like as if it was, let me try and get a pointer here. This almost looks like it's something that was passing through a tube. Okay, so you should think that this is something that was passing through a tube. These kind of look like red blood cells if you were to actually look at it. So this is most likely a red blood cell in a hyaline matrix. These are what you see in nephritic syndrome. Remember that the difference between your nephritic syndrome and your nephrotic syndrome are pretty much going to be some special clinical features, like, for example, you're going to have these red cell casts in the urine. Remember that the red cell casts are pretty much going to be signifying that there is some sort of inflammation and there is some sort of damage that's happening at the level of the glomerulus. And this is going to mean that because of this inflammation that's going on, the glomerulus is bleeding and you get this passing through the renal tubule, and that's how it ends up having this shape that looks like a pencil. I don't know, some people refer to this as a pencil-shaped structure. So it's pretty much your red blood cells in a hyaline matrix. Then this is pretty much going to be diagnostic of nephritic syndrome. Now remember that the triad that you're going to have in nephritic syndrome is pretty much going to be your hematuria, your subnephrotic range proteinuria. And remember, for you to say that someone has nephrotic syndrome, they need to lose over 3.5 grams of protein in a day. That's referred to as massive proteinuria. So if someone loses less than this, but they have blood in their urine and they have hypertension, then it's most likely that it's going to be nephritic syndrome. So usually this is going to be associated with an underlying inflammatory condition. So always take note that there is always an underlying inflammatory condition in nephritic syndrome. Unlike with nephrotic syndrome, there are some variants of nephrotic syndrome. So things like membranous nephropathies and those other membranal proliferative disorders, those may also be associated with some injury to the glomerulus. But strictly speaking, most of the nephritic syndromes are the ones that are going to be associated with your pretty much your inflammation and your damage to the glomerulus. Now I'll move on to the next station, which is station 2. So we have a 45-year-old lady that presents to the outpatient department with chest pains. List focused questions you would ask the patient in your history that could help you arrive at your diagnosis. Now remember that here, always assume that you're taking a history. This is how I usually work it out. I always assume that I'm taking history. So a patient comes to me in the emergency department and this patient has chest pain. What things am I going to ask? They've already given me the age of this patient, so it makes no sense for you to say demographics and you say age. I've already told you that the patient is 45 years old. I've already told you that this patient is a female. So demographics are pretty much not so important in this case, unless if this individual maybe traveled to a different place. But of course, that will also be stretching it by a long distance. So the first thing that you're going to be doing is your presenting complaint will be chest pains. Now remember, whenever you're having any type of chest pain or any type of pain in the body, you should use the Socrates, the site, onset, character, radiation, alleviating factors, exacerbating factors, the timing, onset, the severity, or as well as the associated symptoms that are going to be there. So the first thing that you'd ask this woman is, of course, where is the chest pain? So the chest pain, is it central? Is it in the periphery? Then in addition to that, you're going to be asking this woman, what about the onset of this? When does it start? Is this the first time this has actually started? And what's the character of this pain? Is it a sharp type of pain? Is it a stabbing type of pain? Is it a dull kind of pain? And is there any radiation? Because remember that there are specific things that are going to be radiating. Think of it like this. You are thinking of conditions in your mind that can present to you with chest pain. So if we actually were to play a game of these conditions, you would divide them as respiratory conditions versus cardiovascular conditions. The respiratory conditions will be things like pneumonias, maybe things like your pulmonary embolisms that may cause respiratory pain or chest pain that is due to respiratory causes. Then you're thinking about things like cardiovascular causes. So things like, for example, myocardial infarction, an acute coronary syndrome, and a dissecting aortic aneurysm. Those are the things that are going to be presenting you with a central type of chest pain. And the nature, of course, is also going to be pointing us towards the character, pointing us towards the cause. Is it sharp? Is it stabbing? Is it dull? Does it radiate to any place? Sometimes it can be just in the epigastrum. Sometimes it may radiate to the back. Sometimes it may not radiate at all. Then what are some of the aggravating and alleviating factors that this person is going to have? So, for example, if they have dyspnea, if the pain is worse, is relieved by rest, then you could be thinking that this is a cardiovascular in origin pain. Do certain positions exacerbate their pains? Because there are certain conditions that are made worse by certain positions. For example, if someone has a pericarditis and they lie flat, they'll be in pain. It's usually relieved when they lean forward. So these are the characteristic things that you're going to be looking out. Even when you're thinking about your history, you also ask about things like analgesia. You ask about things about respiratory movements, because you know that pneumonias with respiratory movements, if you've ever had a pneumonia before and you actually take a deep breath, it becomes very, very painful. So respiratory movements tend to worsen pneumonias. Now, is this pain constant or it's intermittent? Does it come and go? What are the exacerbating factors? Does exertion make it worse? And what are the associated symptoms? Because you're thinking maybe this could be TB. Is there any cough? And if there is a cough, is it productive? What is present in the cough? Is it blood? Is it frothy? What's the amount that's going to be present? And what's the color going to be like? And of course, you ask for a history of a fever, night sweats, weight loss, anorexia, all of which are symptoms that are going to be pointing you towards TB. Then you're also going to be having your past medical history. Of course, a past medical history of TB. Have they been treated with TB before? Has there been any TB contact? Now, what's most important here is that the TB contact must be at least 2 years. You can't say, no, this person had TB 5 years ago, and maybe it's a grandmother that stayed 5 years ago in the village. That doesn't make any sense. Okay, it should be recent, within the past 2 years. Then, of course, you should also ask about a history of them traveling, especially a long travel. And why am I asking this? It's because DVTs can dislodge, and emboli can actually go and block the lungs. Then they may also have a myocardial infarction. Also ask about a history of a myocardial infarction. It's very important also to ask about a history about smoking, as well as a history about drinking. So keep in mind, like as if you're taking a history, and ask yourself, what conditions would I ask? What specific questions? It makes it a whole lot easier to discuss these type of stations that way. And you keep this in mind. It can be anything that they may bring you. They may bring you someone coming in vomiting, someone coming in with abdominal pains, someone coming in with a headache, someone coming in with jaundice, someone coming with seizures, and they ask you to take a history. Just imagine that you're taking a normal history. So a third station is a patient who presents with a 4-day history of projectile vomiting, neck stiffness, has been scheduled for a lumbar puncture. This tends to surprise a lot of people on the exams. I don't know why. So explain the steps you would undertake when you are doing a lumbar puncture. I hope we're all together and we're following the schematic of how we're going to be approaching these OSCE stations. This is very important, not just for the 5th years, but even for the final years. As you have seen, most of the questions, it's possible to actually administer an OSCE station to 5th year. The same OSCE station can actually be given to the final years. And you find out that students will still fail both stations because the principle is what they're lacking. So that's what I'm trying to teach you, the principle of how to approach these OSCE stations. Now, remember, when it comes to any examination, any procedure, the first statement that you must always write is pretty much you greet the patient. Oh, hi, Richard. I can see you on the chat. The first thing that you must always do is greet the patient. Do not forget to greet the patient. Gain consent. Because remember, with lumbar punctures, there is a lot of aversion towards the lumbar puncture, where patients feel like if I get a lumbar puncture, I'm pretty much going to die. So what are you supposed to do? First of all, greet the patient, identify the correct patient. You don't want to do a lumbar puncture on someone who doesn't need a lumbar puncture. So identify the patient, gain consent. Now with lumbar puncture, it must be a written consent. The patient must actually sign in the file that they have consented to actually getting a lumbar puncture. And remember that if the patient is not really in a state in which they can reason, then their next of kin is supposed to sign up for that, which should be a relative. The law doesn't allow for spouses. For some reason, the law doesn't allow for spouses, because there was one time when I found myself in a situation where the patient needed a lumbar puncture. The husband needed a lumbar puncture. The wife was there, but she couldn't sign because the next of kin, I think, was the elder brother. So I don't think the spouses actually are going to be pretty much able to sign the consent. So we want to identify the patient. Like I said, greet the patient, introduce yourself, gain consent. So there should be some confidentiality and there should be some privacy. So I'll just digress a bit from here, and I will just pause a bit, because there's a station that I haven't included in these things that can sometimes come for your OSCE stations. Now, sometimes they may ask you, cancel this patient. This patient is scheduled for lumbar puncture. How would you cancel this patient? That's one station that you may be asked. So with all counseling stations, there's always a schematic that you must always follow. The first thing is greeting the patient. So say, hi, my name is Moses. I am a final year student. I've been asked to talk to you about a lumbar puncture. So greet the patient, introduce yourself, gain consent. After that, ask them what they know about lumbar punctures. Okay, if they'll tell you some information or not, depending on whether it's a physical OSCE station or it's a projected OSCE station. Of course, if it's a projected OSCE station, they won't tell you anything because it's just you and the paper. If you're hearing voices, then that's on you. So pretty much you want to ask them what they know about the lumbar puncture, then explain the procedure, how the procedure is done, why the procedure is done, and the benefits of doing the procedure, the complications of the procedure. Then after that, ask them if they have any questions about the lumbar puncture, and most likely they will have questions. They'll ask you about why some people say that when they get the lumbar puncture, they're going to die. Then after that, if you have addressed all their concerns, then you thank the patient and you get the signed written consent in their file. That's how you're going to be counseling a patient that's going to be going for lumbar puncture. Ensure that there's some privacy and confidentiality in these matters. So now back to our OSCE station where we're going to be doing a lumbar puncture. So we want to position our patient. How are we going to position our patient? So there are two ways in which you can do this. If you have ever been to theater, if you've ever rotated in surgery, well, one way is pretty much having to sit, like if they give spinal anesthesia, or rather the anesthesia that is given for patients that are about to deliver via C-section. That's one position. So the patient can actually be seated upright and they'll flex their shoulders. So their shoulders will be brought inwards like that as much as possible, and so that the spine can curve backwards to open up the spaces. That's one way in which you can do this. Of course, this can't be done in patients that are unconscious. The other way in which this can be done is, of course, the patient is going to be lying now on their left lateral decubitus position, so the fetal position. So just think of like if you've ever watched horror movies, a child that's seated in the corner with their legs on their chest, and they are holding their legs in that manner, such that now they form a C in the spinal cord. So their head will be flexed as much as possible. Then this is supposed to open up the space in the vertebra. So you're going to be identifying the puncture site. Now, what are your landmarks? So you're going to be having your posterior superior iliac spine. You draw a line joining those two at the back. So now you have the vertebral processes right in the center. So you're going to be having your the mark, the same level there. If you just go the space above, that will be between L4 and L5. So usually you palpate L4, L5. We'll also palpate L3, L4, as well as L5, S1. Whichever one is the most open is the one that we go in. Now you're going to be marking that position, and remember that this is a very sterile procedure. So there's a particular way in which you're going to be putting on your gloves. So it means that you're going to be marking the area, then you're going to have to clean it with your iodine solution first, your methylated spirit. If you want to be thorough, you can even use your what do you call that thing that they use in theater, Savlon. Then pretty much you're going to be using your 20G needle or your spinal needle. It's advisable you use a spinal needle. So you're going to be wearing your sterile gloves. And then you're going to be advancing the needle right in front. I think I have a cannula somewhere down here. Don't ask me how, don't ask me why, but I think I have a cannula here. So let's say this is a spinal. Let's say this is a spinal needle, yeah? This is a spinal needle. So this patient now will be lying like that. And let's say this is their back. So you're going to be advancing it in a parallel to the flow. As you can see, this is parallel here to the flow. So you're advancing it like that straight towards the umbilicus. You're going to feel some pressure until you feel a certain given, so that there'll be a certain drop in the pressure. Once there's now a drop in the pressure, that means you have now gone through the ligamentum flavum. So then you're going to see a flow of CSF. So you can actually estimate the opening pressure based on the flow. You can collect now at least 3 samples in the red top bottles. You're going to be collecting 2 of them that should be sterile because they're going to be sent to microbiology. You're going to be collecting another one that's going to be pretty much going to be sent to biochemistry. Now, these 3 things, in one of the, get some sample for one of the CSF, where you're actually going to be dropping it in pretty much your dipstick to check if there's any white blood cells. If you use your urine dipstick and you actually dip it in the CSF, and if there are white blood cells, it will actually show you a positive result. Then, of course, after you've now isolated your samples, you label them and you send them to the lab. It's very important that you must also draw blood and check the blood glucose of this patient. Why? It's because you're going to be comparing the blood glucose of the patient to the CSF glucose. Remember that the CSF glucose is roughly about 2/3 to about 1/2 of your plasma glucose. So if you don't know the plasma glucose, it's very hard to estimate your CSF glucose. And of course, one bottle is going to be going to microbiology for gram staining, for culture sensitivity, as well as for acid-fast bacilli. The other one is actually going to be going for hematology, where you're going to be sending it for a cell count and a differential. Remember that in a normal CSF, you should have less than 10 red blood cells per high power field and less than 5 white blood cells per high power field. So keep that in mind and keep these findings in mind. So that's how I would approach this station. So just imagine that you're doing the lumbar puncture yourself. Then moving on to the next station, which is a rather interesting one. A 45-year-old patient has just been diagnosed with hypertension. He is not being admitted, but will be treated as an outpatient. List specific counseling points you will discuss with the patient in relation to diagnosis. Remember when I was telling you about counseling the patient? Now here's a scenario where you're now actually counseling a hypertensive patient that has been newly diagnosed. And there are some important things that you're going to be looking at. So of course, they're going to be your specifics. You're greeting the patient and introducing yourself. All that stuff is out of the way. We already assume that you've already greeted the patient and you've already introduced yourself. So the 3 points that we're going to be focusing on are pretty much, number 1, your lifestyle modification. So you should counsel this patient on the low salt intake. So remember that the salt actually shouldn't be added over the table. The amount of salt should be added before the patient actually cooks or during the process of cooking food, it shouldn't be added over the table, and there should be some salt restriction. Then of course, exercise. Tell them to exercise within their limits. It's very important that you say exercise within the limits, because people tend to actually overdo things. So exercise within the limits, and generally a good exercise is swimming. The best exercise actually is swimming. Walking is not so good on the joints, same thing as cycling, but swimming is the best exercise. But of course, we live in a third world country, and how many people even on this stream can swim? Then you also advise them to have the low fat foods. You're going to be having them also to avoid red meats. Stress management is very important. If they're living a stressful lifestyle, you tell them to relax. You get some time off, some stress relaxation techniques, of course, things like yoga. Then you're also going to be looking at your pharmacological counseling. What is very important is this patient must adhere to the treatment, compliance and adherence. Now, this is one thing that most hypertensive patients must know, is that even if they are not feeling okay, they should take the medication. Even if they're feeling okay, they still should take the medication. Whether they're okay or they're not, that's a very important point to actually put across. Then, of course, you should counsel them on certain drug-to-drug interactions. Of course, there are some drugs that we don't give with other drugs. In case of hypertensive patients, we don't mix certain drugs. For example, if you put a patient on ACE inhibitors and then you also want to put them on angiotensin receptor blockers, that doesn't make sense, because both the drugs are pretty much working on the same system. It's like you buying sugar from Spa, then you go buy sugar from Choppies or something like that. You still have the sugar, it's the same thing. Then also counsel them on side effects. There are some important side effects with these drugs. For example, with the ACE inhibitors, they tend to cause a cough. They also tend to cause a swelling of the ankles. They also tend to cause angioedema. It's much less with the angiotensin receptor blockers. Then the vasodilators tend to cause headaches. The drugs like nifedipine, but it's much less with amlodipine. So if they're having headaches with nifedipine, they can switch. And tell them to actually come in for review when they notice these side effects. They shouldn't just stay home. And of course, the other facts, for example, like I said, hypertension, there's no cure. It's chronic. They'll have it for life. They have to take the medication. And there will be some complications if they don't take the medication. Now, remember that this medication doesn't really stop the complications. It just slows them down. So eventually, they're going to have to deal with these complications one way or another. Of course, we don't wish our patients bad, but there is a high risk of stroke. There's a high risk of visual pathologies. There's a high risk of kidney as well as heart diseases. Then, of course, you also should encourage them to take their BP at home. So they should have a BP profile and should be checking it at least 3 times a day. And of course, there are some false myths. There are some people who believe that water solves everything and water is the fix for every single condition. Those people that are pro-water, the water therapy, just drink water and be happy. I'm not going to mention any names here, but water is pretty much killing a hypertensive patient if they take water as a hypertensive patient. Then we move now to the next station. A patient presents with lower limb pain and swelling of the legs after 2 days on a long bus ride. He is obese and smokes. Take a focused history. So when it comes to these focused histories, it's very, very important that imagine that you're in this situation and you're actually seeing this patient in front of you and you're taking a history in casualty in a male. You're not going to have enough time to be asking, no, do you have how many toilets do you have at home? That's not going to work. So you should think in mind, what are they leading me towards? What is causing this? So this person has lower limb pain, they have swelling, they have been on a bus ride. This is a risk factor for deep vein thrombosis. So your history should be focused towards deep vein thrombosis. So you're pretty much going to be looking at your demographics. They haven't given you the age in this case, so the name and the age of the patient, the occupation, in what capacity were they traveling? Are they a truck driver? Are they an office worker? Where do they stay? Is the pain associated with work? Because sometimes you may get some pain in the lower limbs that comes out with working. It's known as intermittent claudication, where you get this pain as the person keeps walking. So what relieves the pain and what aggravates the pain? Remember your Socrates. Anywhere where you have pain, use Socrates. It'll get you marks. Is the patient experiencing any fevers? Was the patient wearing any tight shoes on the bus ride? And are there any other associated symptoms aside from the limb and even the swelling? For example, chest pains or even coughing. This could mean that the the emboli has actually dislodged and gone to block the pulmonary vasculature and actually resulted in a pulmonary embolism. Then has this happened before? Is there any history of anyone else in the family having a similar condition? And if it has happened before, what was done to solve the problem? Did it help? And does the patient have, or any of the family members have the following things? A history of diabetes, these are risk factors of DVT. A history of hypertension, a history of epilepsy, a history of TB, and a history of HIV. Hi, Nicole. Just in your text message here. Then also, is the patient on any medication? If they are on any medication, what kind of medication are they on? And does the patient drink? Of course, they did say smoking. So yes, the patient does smoke. So how much? For how long have they been smoking? How much do they drink? And for how long have they been drinking? So this is very simple. These questions should be very simple. These are free marks on Osce stations. Then moving on to the next station 6, 33-year-old man presents for routine medical checkup. The registrar on duty requests you to examine the abdomen. Outline clearly all the steps you would take to check the liver span. List 5 differentials for hepatomegaly. Now, I often get surprised with many people that I interact with. Wow, why do I get surprised? Or how do I get surprised? They tell me this. I've watched all your videos on your channel. The lecturer brought something different. It was hard. You see, that doesn't make sense. Let me explain, okay? Whenever you're studying, you should always put your mind in the shoes of the examiner. So if in this case here, the examiner is asking you to check about the liver span, it would mean that in another scenario, the examiner may ask you about the spleen, how you're going to examine the spleen, and things that are going to be causing splenomegaly. This is how, even when you're studying and you're looking at these Osce stations, or you're listening to these videos, or you're on this live stream, that's how you should actually think about it. So just like any other examination, you should always start off with greeting the patient, introducing yourself, gaining consent. So you should expose the patient adequately and place them in anatomical position. So they should be in bed. Now remember that your palpation of your liver is going to begin in the right iliac fossa. And you're going to be asking the patient to take deep breaths. So you're going to be using the radial aspect. Remember that when you're in anatomical position, you're pretty much like this. So this half here, or this bit here, this is known as the ulnar surface of your hand. This is known as the radial surface. Where your thumb is, that's known as the radial surface. Now, your thumb here is going to be at the radial surface. I see a question here that says, what's the importance of tight shoes in the case? Hi, Tandiwe. So the importance of tight shoes in the case is because in certain individuals, especially in those that have, so this is on the previous case on DVT. And certain individuals that have had DVTs before, they may actually tell them to wear tightly fitting shoes, compression socks. Sometimes even the swelling could be due to the pain. If you have ever worn a tight shoe and walked, I remember there was a day I wore a very tight shoe and I walked, your limbs will swell. So that could also be a reason why the limbs are swelling. Or sometimes it could be just part of management, because generally patients that have had DVT before, we usually advise them to get these compression socks. So I hope that answers your question. So now coming back to this, we use our radial surface of the palm, and you're going to be moving 2 centimeters every time the person takes a breath. With each breath, you move 2 centimeters upwards towards the right upper quadrant. Now, this, once you now feel the edge with your radial surface of your what do you call this? The hands, then you're going to be marking that. You have your mid-clavicular line. So you have the clavicle here. So now your mid-clavicular line will be halfway like that. And you mark that position. Now, after you mark that position, now you're going to start percussing from the second intercostal space going downwards along that same mid-clavicular line. You'll reach a point where there will now be some downess. Now you measure the distance through the first point that you marked to the second point that you marked. That's going to be your liver span. And now the next question, if I was a lecturer here, another question that I would ask students here is, what is the normal liver span? So I really want you to have a look that up, and check what the normal liver span is. Then, of course, thank the patient and cover them up. Then 5 differentials for hepatomegaly. This is quite easy. Quite easy. Whether it's 5th year or 7th year, you should be at least be able to give me even 6 or more differentials. So it could be things like right heart failure. It could be things like viral hepatitis. It could be things like alcoholic fatty liver. It could be things like alcoholic or non-alcoholic fatty liver disease. It could be things like metastatic or even primary malignancies. Glandular fever. It could be things like leukemias, even lymphomas, and even sickle cell. So I'm seeing some questions here. So is there a specific reason we start the palpation in the right iliac fossa? Yes, there's a specific reason why we start the palpation in the right iliac fossa. The reason is because of how the liver grows. So sometimes this is actually another potential question that they can ask you on your Osce stations, where they ask you, how does the liver grow? The liver is going to be growing downwards. So it grows downwards towards the right iliac fossa. So you're starting from the right iliac fossa because we're assuming that this patient could have massive hepatomegaly. When you're palpating for the spleen, you're going to be starting also from the right iliac fossa, moving diagonally in that manner, because the spleen grows diagonally towards the right iliac fossa. That's the rationale why we're starting in the right iliac fossa. So I hope that answers your question. Then, moving on now to station 7, a wife brings her unconscious husband to the emergency department claiming he has been convulsing. Take a relevant history. This is the exact same thing. Now, I shouldn't be wasting time on actually talking about the relevant history, because by now I think you get the gist of how you should be taking these histories. So what questions are you going to ask? First of all, we'll ask about the name. The age of this patient is very important. Very old, tumors, brain tumors. Very young, infectious processes. Young, infectious processes, or trauma. The way they stay, of course, this could be because of malaria. Generally, we assume that if they're coming outside of Lusaka, then they have maybe could have contracted malaria, because malaria is one of the things that can cause a patient to be unconscious and they can be convulsing. Then, of course, how does the wife describe the convulsion? Remember, whenever it comes to dealing with convulsions, you should think of 3 things. In every convulsion, there should be a pre-ictal, an ictal, and a post-ictal. Pre-ictal is the events that happened before. What was this patient doing before the convulsion? This is sometimes a trigger. Were they complaining of certain things? Because there is something that's known as an aura. If you've ever handled a patient that has convulsions, they'll tell you that sometimes they know when the convulsion is about to come. Now, the auras are pretty much characteristic of partial seizures. In generalized seizures, we rarely see auras, unless if it's a partial seizure that has secondary generalization. So you start off with an aura, then after that, this aura, maybe they start seeing things, they may start hearing things, they may just start feeling unwell. Sometimes it could be just some abdominal discomfort. Then what happened during the seizure? Did the patient lose consciousness? Was it part of the body, or was it the whole body? Excuse me. Was it part of the body, or was it the whole body? Then, of course, did the patient fall during the convulsions? What were they doing, or what did they do after the convulsions? Did they regain consciousness and convulse again, or they have just been unconscious through and through? Now, have they experienced any fecal or any urinary incontinence? Did they have any memory episodes or any other episodes of memory loss, episodes of visual disturbances, episodes of taste disturbances, episodes of hearing disturbances? Was there any trauma in this patient? Have they eaten any pork or any undercooked meat? It's weird. I'm going to attack STAs. I've nothing against STAs, but don't you think it would be weird if an STA got neurological cysticercosis? Because that would mean that they're eating pork. And anyways, I'll let you finish that joke on your own. So is there a history of fainting? Is there a history of blackouts? Is there a history of seizures? And ask if they or anyone in the family has history of diabetes, hypertension, epilepsy, TB, HIV. Because these are all conditions that can actually present you as seizures. Sorry, I have a very, very bad cold that's refusing to go. So ask if they have had any similar illness and what medication are they on. If they are, what is the dosage? What is the frequency that they're taking the medication? Does the patient drink? Does the patient smoke? And of course, ask the wife if she can tell you anything else. That's what you're going to be doing to approach a patient that pretty much has seizures. Then we'll move on now to station 8. Again, headache for 3 weeks. Guys. And then if they bring you, what can they bring you in the exam? If they bring you abdominal pain and then you say that we didn't cover it on the channel, I'll be very disappointed in you. So if they bring you any history question in the exam, that's your station. You'll be like, my time has come. This is the time. So headaches for 3 weeks. What are you thinking? Trauma? It could be that this person has an infection, a chronic infection. So you should also be asking history questions that are going to be pointing you towards things like immunosuppression. If it's chronic, 3 weeks it's quite a long time for someone to have 3 weeks. Maybe someone has migraines. Think of migraines. Those are the things that you should be now keeping in mind when you're taking your history. So again, Socrates, location of the headache, generalized. Is it localized? Is it occipital? Because remember, there is that diagram, that diagram, I don't know if it's a meme that goes around where it shows you the different types of headaches and where you feel them. But most commonly, the hypertensive types of headaches are the ones that we see. Even in pregnancy, we see them mostly at the occipital region. The timing of the headache, if it's intermittent or constant, the character, if it's throbbing, if it's pounding, if it's piercing. Is it associated with, or is it alleviated with any painkillers? Is it associated with any aggravating factors like light, like sound? Because these are factors that are going to point us towards migraines. Remember that there are different types of headaches that exist out there. Different types of headaches. And what are the associated symptoms? Are there any seizures? Has this patient fainted before? Are there any visual changes? Do they wear glasses? Are there any hearing problems? Any sensory loss? Any neck stiffness? Any fevers? Any vomiting, any projectile vomiting, palpitations, any lightheadedness, even dizziness? Are they taking any drugs? Of importance, remember we talked about nifedipine in our previous station on the hypertensive counseling. Then of course, past medical history for HIV, migraines, hypertension, diabetes mellitus, anemias, history of any trauma. And then of course, if they have any family history of migraines. Now here comes the pictures. I think now the ones for the history taking, I've had enough of that. So here comes the pictures. So station 9, a 26-year-old patient presents to a male complaining of generalized body pains. More so the back. He is known to have a disease from childhood for which he has been treated in pediatric wing of the hospital among various tests done in the following. What abnormality can you see in the picture? What is the diagnosis? What are the complications of the disease? Name 8. How do you manage the condition in which the patient has presented? Now, if you ever miss this, guys, if you ever miss this, then I don't know. Whether you're 5th year, 7th year, even 4th year, if you ever miss this on a station, then I don't know what you want to get in life. I honestly don't know. So what can we do? They're just asking you now, what can you see on the peripheral smear? So as you can see here, we can see that there's something going on here. Even though this picture is poorly taken, there's something going on here. We have these cells that look like a bullseye. You can see that there's a darker area here, and there's a lighter area in the middle. A darker area here, there's a lighter area in the middle there. These are known as codocytes. We can refer to them as target cells because they look like a target. Some of these, they're different shapes that you can see here. Some of these are almost even sickle shaped. Almost, I'm saying almost. Now, if you look very closely, I don't know about the resolution on your screen, but if you look very closely, especially when you focus at this red blood cell, I think I can zoom this. Let me just try and zoom this so that you can see what I'm talking about. If you look very closely at this red blood cell, you can see that there's this bluish thing that you have in the cytoplasm. Even here, you have a bluish body in the cytoplasm. These are known as remnants, the basophilic remnants that you see in the cytoplasm of these red blood cells. These are known as Howell-Jolly bodies. Whenever you see these Howell-Jolly bodies, know that someone functionally is asplenic, meaning functionally the spleen isn't really doing its job. So those are Howell-Jolly bodies. You can see them also in this condition, which happens to be sickle cell. So What are we going to see? We're going to be seeing sickle-shaped red blood cells. We're also going to be seeing some codocytes or target cells. We're also going to be seeing some Howell Jolly bodies. So because this patient presented to us with pain, so they are probably in a vaso-occlusive crisis in sickle cell disease. Now, it's very important that you distinguish between these three things. And that should be, I hope you guys are writing down these take points that I am using as sidebars that are not going to be on the lectures. They're very important for you to revise and broaden your knowledge. So three things. I want you to distinguish between sickle cell anemia, sickle cell trait, and sickle cell disease. If you think that they are the same, then I don't know, but distinguish between the three of them. So what are the complications of the disease? With complications, a nice trick that I always like to learn, if there are a lot of complications, I like to do them head to toe. So meaning that I think, what are CNS complications of sickle cell? It could be a stroke. This person could have retinal hemorrhage or retinal detachment. They could have acute chest syndrome. They could have heart failure. They could have arrhythmias in the cardiovascular system. They could have a vascular necrosis of the head of the femur, even a vascular necrosis of the head of the humerus. They could have osteomyelitis. Now remember that osteomyelitis in sickle cell patients is more or less going to be caused by your salmonella. Osteomyelitis in generally is caused by Staph aureus, but specifically in sickle cell patients is going to be caused by your salmonella. Then of course, how are we going to manage this patient, especially for the final year students? We admit this patient. IV rehydration in sickle cell patients is very, very important. A blood transfusion may be needed for this patient, and of course analgesia is very important. We usually give analgesia judiciously, even if it means that giving this patient opioids, but because remember that opioids have a risk of dependency, so that's why some people are usually hesitant about giving them. But the newer guidelines say do as much as you can to prevent this patient to being in pain. So if they need opioids, please give them opioids. Now, here's one station where most people now are going to be like, eesh, it has come, finally. So, station 10. A 35-year-old lady was doing her medicals to travel for her master's degree. The following was her test results. Read this test and give your findings. What is the diagnosis? Give the full name of this test. Okay, so someone is asking a question in the chat. Hybrid, name Hybrid, I don't know, by the name of Hybrid, asking about why Salmonella is common in patients that have sickle cell in osteomyelitis. Remember that patients that are sickle cell patients, generally by the age of somewhere around 6, the spleen is already gone. So they undergo a process that's known as autosplenectomy. Now, autosplenectomy predisposes an individual, because now they lose the complement system, the part of the complement. So it predisposes this individual now to becoming susceptible to being infected with encapsulated organisms. Salmonella is an encapsulated organism. Another encapsulated organism is pneumococcus. So that's the Streptococcus pneumoniae. So it means you have to vaccinate them against pneumococcus, and you have to do everything in your power to prevent salmonella. So that's why salmonella is actually very, very common in patients that are sickle cell patients. I hope that answers your question. So here, station 10, we have a 35-year-old lady who is doing medicals to travel for her master's degree, and the following was her test result. Read the test and give your findings. What is the diagnosis? Give the name of the test. Okay, so I think here what everyone can answer is the third thing. They all know that it's an ECG, but of course ECG just simply stands for electrocardiography, or you can say it's an electrocardiogram. So electrocardiogram is the piece of paper that you're seeing on your screen. This is known as an electrocardiogram. The process of actually getting this same paper is known as electrocardiography. Okay, so it's can either be abbreviated as ECG or EKG. It's just pretty much the same thing. Now, let's have a look at this ECG and see what's really going on in this woman. So the first thing that you should always look when you are reading an ECG is obviously the details of the ECG, the name of the ECG, the age, the indication, why it was done. So keep in mind that this person is doing an ECG because it's for medicals. Okay? So I don't want you to start seeing things that are not there, because your mind will play tricks on you. Even in the exam, you start thinking and you start seeing, no, the P waves are not there. They are there. Okay? So The first thing that we look at is, of course, the details of the ECG. Then we now come and ask ourselves, are the P waves present? So a good start is to start from the lead 2. We can use this. You see these long strips here that go up from here to the last here. These are known as rhythm strips. You can use them to determine your rhythm. So you look first and see P waves. Are they there? Okay, there's a P wave here. There's a P wave here. There's a P wave here. There's a P wave. You do it for 3 consecutive P waves. Then you're like, okay, fine, the P waves are there. What's our next thing that's going to be there? Are the P waves before each Qrs complex? We check. Okay, the P waves are before the Qrs complex, before the Qrs complex, before the Qrs complex, before the Qrs complex. That's fine. Okay, so the P waves are present. They are before the Qrs complexes, and they're upright. Okay, remember that the only lead where you get P waves, which are all the other things that are inverted, is lead AVR, because of the way the ECGs are connected. I have a nice series on my channel on ECG, on everything, explaining how to read ECG. Is a very detailed thing. If you're preparing for Osce examinations on Thursday, then I think you're too late to actually watch that series, but I'll give you a brief crash course here. So the only waves that are inverted are AVR. So don't look at AVR and say, oh, the P waves in AVR is inverted. No, that's how normally they are. So the P waves are there. They're followed by a Qrs complex, and this is followed by a T wave, right? So it means that this person, most likely the rhythm is regular. You want to comment on the rhythm first. So now a quick way to check for the rhythm. Now this comes with experience. The more ECGs you see, the easier it will get for you to now look and say, okay, this rhythm is not regular. So if I just look at this rhythm myself, you're just looking at this rhythm, it looks regular. How do I know? If you were to actually get a piece of paper right now on your screen and you mark this, you see this, you mark you mark on your paper this point, then you also mark this point, then you move your paper along this ECG, you find that the spaces in between the R waves are exactly the same. That's how you know that the ECG is regular. Okay, so the first thing is that this ECG is regular. The second thing is that we're coming to the rate. Now, how exactly are we going to determine the rate? Here is now we have to do counting. Okay, we look at the big boxes and the small boxes. So you count the number of big boxes between the RR complexes. Then you divide 300 divided by the number of big boxes. Get me right. 300 divided by the number of big boxes. These are my big things. I don't know if you can see the lines on your screen, but this is one big box. One big box is equals to 5 small boxes. So you count the big boxes between the R waves, and 300 divided by that, then that's your rate. Or you can say 1,500 divided by the number of small boxes, because as you can see that there are going to be some Qrs complexes that just don't coincide exactly to start where a big box is and to end where another big box is. So you can say 1,500 divided by the number of small boxes to find your rate. So if we count the number of small boxes here, I'm not going to spend much time counting that. You can count that on your time, but the rate I think here looks like it's coming up to somewhere around 86 beats per minute, or rather 83 beats per minute, somewhere there between 80 to 90 beats per minute, so which is normal because the normal heart rate is 60 to 100. Then the P waves are present, the Qrs complexes are present. They're not narrowed, they're not broadened, they don't look bizarre, they're normal. Then the next thing is we look at the T waves. The T waves are not peaked generally, they're normal, they are present everywhere. Then we now come to what is known as the ST segment. Sometimes the ST segment can be elevated. I'll show you an ECG where the ST segment is actually elevated. You can't miss it. So here the ST segments are pretty much normal. The ST segments, as you can see, they're pretty much normal. They're on the isoelectric line. If you were to draw a line from here straight through, you'd see that all your ST segments are across this line, which is known as the isoelectric line. Then the last thing that you check, of course, is your RS wave progression. So as you're moving from V1 to V6, the R wave is supposed to get bigger. So as you can see, V1 it's small, bigger, it's equal, bigger, bigger, biggest. Then the opposite is supposed to be for the S wave. Small, small, or smallest, small, it's getting bigger, bigger, biggest, and quite big here. So the RS wave progression is normal in this patient. Then the one thing that I left out is your cardiac axis. Now, cardiac axis, you're pretty much going to be looking at predominantly 3 leads. You compare lead 1 and lead AVF, but you should also consider looking at lead 2 and lead 3. The rule of thumb is this: if lead 1 and lead AVF are both facing upwards, then that's a normal cardiac axis. If lead 1 and lead AVF are facing each other, meaning lead 1 is facing downwards, lead AVF is facing upwards, kind of like as if they're kissing, you call that as your right axis deviation. If lead 1 is facing upwards and lead AVF is facing downwards, then you call that as your left axis deviation. So I hope you keep that in mind. Here's a mnemonic to help you remember. Right reaches, meaning right is like they're reaching out to each other. Right reaches, meaning lead 1 and AVF are reaching out to each other. Left leaves, so they're leaving each other. So keep that in mind, and I hope it makes sense. Okay, so this person has a rate of about 83 beats per minute, like I told you. The rhythm is normal. The cardiac axis is normal. The P waves are present, they're normal. The PR interval is normal. The Qrs complex is normal. Remember that the PR interval is about 3 to 5 small squares, and it should be constant. It shouldn't be increasing in size. It shouldn't be reducing in size. Of course, this is a very unfair thing as a lecturer to bring as an Osce station, because someone is sitting at the back. You can't really see the small boxes on the screen, no matter how much the lecturer zooms the ECG. Let's just be honest. So this is one very unfair station. I do sympathize with that. But of course, you can tell whether it's normal or abnormal based on certain things on the ECG. So there's a normal T waves, normal ST segment, and a normal RS progression. So this is a normal ECG. So it's possible for you to get a normal ECG on your exam. So you should be looking out for the normal things. You will just be looking for things that are not even there. So first look at the clinical history, the scenario in which they have put you in. And then of course, I've already covered what the full name is. Station 11 shows pictures of similar history or a similar history of illness. They are farmers who present to the various hospitals with generalized body pains and stiffness of the body. They are reported that they do not put on protective shoes. They go about with plowing on their farms. There's no history of fever or no hypertension. On examination, they are fully conscious with no focal neurological deficits except spasms of these muscles. Other systems and are vital, or other things, or vital, what do you call them? Vital signs are normal. Sorry, I had a brain freeze. List the clinical features that you see in the pictures. What is the diagnosis? What is the causative organism? List the complications of this disease. So if you haven't read on this, again, it's one of those things where you'll be lost. You just be looking at your friend in the Osce station and you have no idea what is going on. So as you can see, this thing looks like as if this man is about to be possessed by a demon. Or his soul is about to be ripped out of his body. So this arching of the back, this accentuation, this arching of the back is known as Opisthotonus. I'll show you the spelling in the next slide. I don't know if I added it, but I think I did. It's known as Opisthotonus. Now, this grin, this characteristic grin that they have here is known as Rhesus Sadonicus. This is indeed tetanus, generalized tetanus, or you can refer to it as lockjaw. Because way back, when patients used to get this condition, their jaw would lock. They're not able to eat. So it means in some cases, they actually used to break their teeth to actually force food into their mouth. In other cases, their muscles, their respiratory muscles would paralyze and they wouldn't be able to breathe. That's what usually used to kill most of these patients. So again, even the history is giving you a hint. There's no fever. This person is a farmer. Remember that this Clostridium tetani is going to be found, the spores can actually be found within the environment, or rather this bacterium can be found within the environment, and it can actually cause this. It produces that tetanus toxoid. Then what are the complications of this? Like I said, you could have respiratory failure, you could have aspiration pneumonias, you could have fractures because the muscles are contracting and they are with a great force. And of course, there is also a risk of malnutrition. Here is a station that may or may not come. So below is named 72-year-old grandmother who presented with progressive dyspnea. Look at the pictures and answer the following questions. Describe the anomalies. What is the diagnosis? Describe the other manifestations of the disease. How would you manage this patient? Okay, so as you can see here, this here has this claw-shaped like hands. So these claw-shaped hands, and they have a very small mouth, which is known as a microstomia. You can also see that if you zoom in quite well, you can see that the surrounding of the mouth is it's lighter than the mouth should be. So there is this perioral hypopigmentation. So these two things are obviously seen in a condition that's known as systemic sclerosis. Now, in systemic sclerosis, you may actually have what is known as a Qrs syndrome. So you're going to be having, number one, calcinosis, which may be cutaneous. Number two, you may have Raynaud's phenomenon. Raynaud's phenomenon is where you have this problem that's affecting the blood vessels. Especially the ones going to the digits, where this person may actually have cyanosis affecting the digits or the blood vessels, because the blood vessels are affected in some way because of this condition. They may have esophageal dysmotility, they may have sclerodactyly, they may even have telangiectasias, which are pretty much abnormally dilated vessels. Then, of course, how are we going to manage this patient? So because the skin is thickening in this condition, we can give some drugs that are going to be preventing the skin from thickening. So we can give cyclophosphamide, we can give methotrexate, we can give mycophenolate. These are pretty much cytotoxic drugs that will prevent the skin from thickening. Then, of course, you may also give emollients, you may also give antihistamines, because sometimes there may be some itch that may be involved with this condition. Then, of course, if the patient developed dyspnea, you should give them oxygen. You can cover them on a phosphodiesterase type 5 inhibitor. You may sometimes give them endothelin receptor agonists that can actually be used to relieve some pulmonary hypertension and pain relief. But this rarely comes on Osce stations, but sometimes you never know. You find out that the things that are rarely coming are the ones that are showing up on the Osce stations. Then moving on now to station 13. A 60-year-old female with severe joint pains in the past 5 years. Over the last year, she noticed swelling of her hands or her joints. Describe the abnormality seen. What are the probable swelling described above? What two diseases could be the cause of such a presentation? What lab tests would you order? Name any two drugs used for the treatment. So as we can see here, we have these swellings here that are happening to be at the distal interphalangeal joints, or the DIP. And there is also some erythema that's there, so there may be some swelling of the fingers. There is some polydactyly to some extent, or dactylitis rather, not polydactyly. Polydactyly is extra digits. Dactylitis. So there is some swelling of the digits as well. So most likely that these are either tophi, so they're gouty tophi, or they're Hebden's nodules. And these are going to be seen in osteoarthritis. The Hebden's nodules are going to be seen in osteoarthritis. The gouty tophi are going to be seen in gout, obviously. So you'd want to order investigations targeted towards these two conditions. You want to order things like a fluorescent microscopy, where you aspirate from the joint and you take that for a special type of microscopy, which is known as fluorescent microscopy, where they use fluorescein. Then you can also order for your serum uric acid, which will be elevated in the terms of gout. You may order for urea, creatinine, and ESR, which is going to be raised. Another thing, please, in your Osce stations, do not fall in the habit of writing abbreviations. Write things in full. If you can't write them in full, then don't write it at all. Never write abbreviations, write them in full. So the two drugs that we can either give allopurinol, which is used in gout. We can give NSAIDs, which are used in osteoarthritis and gout. We can use colchicine, which is used in gout. We can use febuxostat, which is also used in gout. Station 14. Another thing, if you have never seen before, you'd never know. So a female 30-year-old patient presents to the clinic with history of nausea. The stool examination shows the following. Describe the picture. What is the diagnosis? Give the life cycle. Outline your management plan. And as you've noticed here, I'm adding even management, or management is being asked of you. So this is not just for the 5th years, but even for the final years, because 5th year, maybe they'll end you at life cycle. Final years, you're expected to even know about management, but even 5th years, you should know about the principles of management. So this is an egg of Ascariasis or Ascaris lumbricoides. So this is a fertile egg of Ascaris lumbricoides. Of course, this is Ascariasis. I'll show you the life cycle in the next slide very briefly. So how do we manage this patient? So pretty much we want to admit this patient if they are in shock or if they are hypotensive. We manage the shock. We give them oral antihelminthic agents. So pretty much your albendazole or your mebendazole. Now these are they're well taken. They're chewed. The tablets that you give them to chew, or you take them on an empty stomach, and that it's best to give them early in the morning before the patient actually eats anything. Then give them IV fluids if they're in shock, or just generally give them some IV fluids. Corticosteroids, because once now you kill these things, or you give them drugs to kill these worms, they release certain toxins that can now, or they release certain substances that can now stimulate your immune system. Once they stimulate your immune system, this can lead to a certain reaction. It's kind of similar to what we see in syphilis, which is a reaction known as the Jarisch-Herxheimer reaction. Very similar thing, but different organisms, of course. So that's why we want to cover them on corticosteroids. Then, of course, we want to, if there's any perforation of the bowel or any bowel obstruction, we want to take them for surgery, so an explorative laparotomy. Here's our life cycle. So you have first of all your larvae, which is, all right, let me not start with the larvae. Let me start with the same eggs that are released in the soil. So you're going to be having, some eggs are going to be fertilized, some are not going to be fertilized. So the ones that are fertilized are the ones that are going to be developing in the environment. So eventually they're going to develop an embryo, and this stage, which has the embryo, is known as the infective stage. So this one over here, the embryonated egg, that's with the second stage larvae, that's the one that's going to be known as your infective stage. Then after that, you're going to have your larvae being released. Once now you ingest this and it finds its way in the intestines, it's going to be released by the same pancreatic juices. Your digestive enzymes are going to release this thing in your intestine, and then of course it enters into the bloodstream and gets a ride, goes to the lungs. They may even sometimes have some pulmonary symptoms. Then it moves to the trachea, eventually goes to the throat, and it is swallowed. Then once now the larvae is swallowed, then now as it's passing through the GIT, it hooks onto the walls of the intestines, and it can now even be passing, what can live in the intestines and be passing these eggs to complete the life cycle. Here's another picture of an ECG, which may be very daunting. A 33-year-old male presents with anuria. Always keep in mind, whenever they give you an ECG, they will give you a clinical history. Don't just look at the ECG and forget about the clinical history. So they present you with anuria for 4 days. So keep that in mind. Anuria, 4 days. They have fatigue, they have breathlessness, and the doctor on call did an urgent ECG, among other tests. So what is the one prominent feature that you see in the ECG? What is the diagnosis? Give treatment options. List 4 possible causes of anuria in this patient. And of course, if you've noticed, there are some stations here that are not in the Bazooka, that are not on my channel, and you're seeing them for the very first time. So please pay attention. So we look at this ECG, okay? In this case, we were not given the rhythm strip, so you can forget about the rhythm strip. So let's look at lead 2 here, okay? There is a P wave, okay? Or what seems to be a P wave. There's a P wave here, there's another P wave here, there's another P wave here. Fine. Let's look at now the Qrs complex. There's a Qrs complex. There's a Qrs complex. There's a Qrs complex over there. Because it's most likely that this rhythm is regular. We look at the axis deviation. We look at lead 1 and lead AVF. They are both facing upwards. So that's already normal cardiac axis. So forget about right axis deviation. Forget about left axis deviation. But now, the Qrs complexes, there's nothing so significant, but I want you now to focus on the T waves. Look at the T wave here. Look at the T waves here. They're actually even much more prominent here on the chest leads. You can see the T waves here. T waves are quite peaked. So the important thing that you're going to be seeing on this ECG are the peaked T waves. Okay, that's the most prominent thing that you see on this ECG, your peaked T waves. And it makes sense, if someone is not passing urine, potassium is accumulating in the body, they have hyperkalemia, which is of course secondary to acute kidney injury. They have the peaked T waves on the ECG. Remember that peaked T waves on the ECG are going to be indicative of hyperkalemia. And of course, how are we going to treat hyperkalemia? Two ways. First of all, if they are symptomatic, obviously, so you would want to actually go get them for dialysis. So you take them for hemodialysis. The second thing that's going to be there in these patients is that you're pretty much going to be, you can give them insulin with dextrose. So 50 mils of dextrose with 10 international units of insulin to run. Of course, this also helps in reducing the insulin level. So dextrose and insulin, because remember that potassium is needed for glucose to enter into the cells. So we can use, that's the second treatment option that we can use to lower the potassium concentration of these patients. And remember the indications of dialysis, your vowels, IAEOU, acidosis, electrolyte imbalances such as hyperkalemia, you have intoxication, you have edema, which is of course your fluid overload, and you have your uremia. Then the 4 possible causes of anuria. So you have things like severe malaria, sepsis, hypovolemia, even shock, lupus nephritis, even glomerulonephritis, just to mention a few. Just pick any 4 from that. Anything that can cause a patient to actually undergo an acute kidney injury can pretty much cause your anuria to happen. Moving on to station 16, the picture shows scans of a 38-year-old patient with HIV infection with a CD4 count of 99 cells per microliter. What is the scan on the right? Okay, this is the right, yeah? What's the scan on the right? What's the scan on the left? What is obviously seen in the scans? Give your diagnosis, give 2 differentials based on the scan, and what contraindications apply to the scan that's seen on the left, this one here. So this one here on the right, this is a CT scan. Okay, how I know is a CT scan? Bone appears quite white on the CT scan, air is rather dark, and the brain tissue is not well defined. MRI on the other hand here, you can see that the brain tissue, can almost appreciate the brain tissue very much here, but not the bone. So this one here is the one that's on the left, on the right. This is known as a non-contrast enhanced CT scan. You're not using contrast here. This one here is an MRI scan, a weighted scan, and they used contrast in this case. Now what we're seeing on this scan is pretty much, we can see these lesions here. There's 2 giant lesions here with an area of hypodensity or area of necrosis in the center there. So remember, whenever on the CT scan, if it appears darker than the brain tissue, you call that as a hypodensity. If it's appearing brighter than the brain tissue, it's referred to as a hyperdensity. So I want you to be using these terms in your Osce station. You can see a hypodense lesion, a hyperdense lesion. Then if it's like the brain consistency, then it's going to be an isodense lesion. So this person here most likely had a CNS lymphoma. How do I know this? HIV and AIDS. CD4 count very low, and the characteristic appearance of the lesion. One would argue and say, what about toxoplasmosis? Now, toxoplasmosis, the lesions tend to be a bit smaller than this, and more or less they tend to be quite multiple, as opposed to them being quite huge like this. This is most likely a CNS lymphoma. So of course, what we have on the right here is our non-contrast CT of the head. On our left here is your axial gadolinium enhanced T1 weighted MRI. If you want, you can just say MRI with contrast, and this one CT without contrast, and you still get the same marks. Then obviously what we're going to be seeing is of course a bilateral lesion in the parietal lobes, the parietal white matter. This is going to be having a central area of attenuation, meaning that this central area that's looking dark here is pretty much going to be where there is the central necrosis that is happening. Then surrounding now this lesion here, you can see that there's some dark area that's surrounding this lesion here. This is known as a vasogenic edema. Then of course here you have a ring that is surrounding the lesion. This is known as a ring enhancing lesion. This ring here that's surrounding the lesions. So this is the CNS lymphoma. Other things that could present in a similar way, you have things like cerebral abscesses, tuberculoma, toxoplasmosis, cryptococoma, that's due to cryptococcus, and of course metastasis. But of course with metastasis, they also tend to be quite multiple and not as huge as this. Then what contraindications apply to the scan? On the left, previous reactions. If they had previous reactions to contrast, if they have AKI or CKD, meaning that they can't get contrast, you can't do the scan on the left. If they have a patient that's on metformin, you can't do contrast scans. If they have metallic implants, because it's magnetic resonance imaging, magnetic, so it's going to be attracting the metal that's there. If they have any metallic implants, don't do an MRI. If they have a pacemaker, don't do an MRI. Claustrophobia is more of a relative contraindication. In some cases, you may actually sedate the patient a bit to help calm their anxiety. And of course, if they are obese, because there's a weight limit for the MRI scans. Okay, moving on to the next question. I see someone in the chat. Will the live be uploaded? Most likely, but sometimes it does glitch. So sometimes you may not find the stream. Sometimes you may. So just stick around. It'll be done in no time. So a female, 40 years, has a history of chronic diarrhea with weight loss. She tested HIV negative 2 weeks ago. Examine her picture above and describe the anomalies, suggest and discuss possible causes of the chronic diarrhea, outline your management plan. So this woman here has HIV. As we can see here, it's like as if she's pretty much opening her eyes widely. So you call that as a wide-eyed stare gaze. And of course, there is some wasting that you have in this patient here. As you can see the prominence of the shoulders here. She's rather wasted. Even the prominence of the cheekbones here, she's rather wasted. So most likely this woman could have a hyperthyroidism. She's HIV negative, but she's lost a significant amount of weight. Hyperthyroidism is what should come to mind. Diet. And it's not just about quantity, but quality of the food that this person is eating. So it could be an adult onset malnutrition. And of course, how we're going to manage this patient, we investigate this patient, we treat the underlying cause. If it's hyperthyroidism, then we're going to be giving them drugs that are going to be blocking the thyroid hormones. So things like carbimazole, things like propylthiouracil. So you can do what is known as a block and replace mechanism, where you block the hormones completely, then you replace them with exogenous hormones, or you can actually remove the thyroid altogether. Then we move now to station 18. Study the image below and answer the questions. Describe the abnormalities in the X-ray. List 3 causes. So X-rays, you shouldn't have a problem with this. Now, here's some terminology that you should use when it comes to X-rays. So if the X-ray is completely white, like completely white, you refer to that as a homogeneous opacity. Okay, it's the same. The consistency is the same. It's completely white. It's a homogeneous opacity. So as you can see here, you have a homogeneous opacity that's affecting the left side of the chest. Now you can see that totally here, there's nothing here. You can see that the trachea here, which is supposed to be in the midline, is shifted to the other side here. So this trachea has been shifted to the right, to the left side. And then this is most likely consistent with the lung collapse. So here you have the complete left-sided hemithorax opacity. We have obliteration of the costophrenic and the costodiaphragmatic recess, which are these things. So this angle here that is formed here is known as the costophrenic angle here. This angle here. So we can't see the costophrenic angle here. Then of course, we have deviation of the trachea to the left side. So these are features that are going to be consistent with the lung collapse. Then the 3 things that are going to be causing this, it could be a pneumonia, it could be a TB, it could be a bronchogenic carcinoma. I think I've covered this extensively on the channel. I'm not going to waste much time on it. Okay, so this one even has answers. I don't know why it has answers. Anyways, a male 48 patient presents progressively with breathlessness and a cough over a period of 2 years. Currently, he is unable to get dressed without experiencing breathlessness. He's admitted and has a 20-pack history of smoking, and the chest x-ray shown. So here's your chest x-ray here. So this is a very, very characteristic chest x-ray. Sometimes they may just give you a PA chest x-ray without this anterior or your lateral x-ray will just give you this. So if you've noticed here on the x-ray here, if we count the ribs, 1 2 3 4 5 6 7 8, there are about almost 9 ribs that you can actually see on this patient. So the lungs are actually hyperinflated. The diaphragm, the diaphragm actually appear rather flattened, and you even have this deep sulcus. This looks like a deep sulcus. You can call this as almost like a deep sulcus sign, but not that deep. Then the lungs here appear like more loose than they're supposed to be. They are hyper translucent, and they're almost shaped like as if this person is shaped like a barrel. Even in this lateral x-ray, they're shaped like a barrel. This person most likely has a COPD, emphysema, because it's linked with smoking, and you get these certain changes on the x-ray. Sometimes you may even get loss of pulmonary vascular markings, which is of course your hypertranslucency. The investigations that you want to do, of course your full blood counts, your arterial blood gases, your spirometry or your lung function tests, and your electrocardiography. Because remember that there is cor pulmonale that can arise from patients with pulmonary pathologies, which is right-sided heart failure. Moving on to station 20, identify the organism in the picture. Name 2 species that cause disease in man. I would actually just say 4 species. Give a brief life cycle of the organism. List some of the complications associated in man. So again, this is one of those stations. If you miss this, then I don't know. This is a typical characteristic station of malaria. So this is your Plasmodium falciparum. Of course, your Plasmodium falciparum trophozoites. These are found in the red blood cells. They are parasitizing the red blood cells. Remember that the ring forms are actually a type of trophozoite. So the species are going to be your Plasmodium malariae, your Plasmodium vivax, and your Plasmodium ovale. Remember that the Plasmodium malariae is the one that's going to be associated with nephrotic syndrome. And the brief life cycle, of course, is the life cycle of malaria. How many times have we gone through this? So you have your sporozoites being injected into the bloodstream. Some of them get destroyed, and then some of them are eventually going to be uptaken by the liver, and then they're going to be entering a stage which is known as your pre-erythrocytic schizogony or pre-erythrocytic schizons. Then these are going to be like these massive structures that have subunits in them that are known as merozoites. So these can actually rupture and then release the merozoites into the bloodstream, where they go now and invade the red blood cells. Now remember that in Plasmodium vivax and Plasmodium ovale, some of the parasitized things, the parasites, can remain in the liver as hypnozoites, later on to be reactivated. So you call that as malaria relapse. Then the merozoites that you're releasing into the bloodstream are going to be infecting the red blood cells and then kicking off the erythrocytic stage, where now the merozoites are going to develop into trophozoites, your early trophozoites, your late trophozoites, and then eventually they're going to rupture and kill off this red blood cell. This is what actually gives rise to the certain characteristic features that we see in malaria. Then, of course, some of the trophozoites actually are going to develop into gametes, the microgametes and macrogametes, that are not going to develop any further in the human, unless if they're taken up by a mosquito, and then in the mosquito, in the midgut of the mosquito, they combine, and then they form a zygote, which forms an oocyst, which forms an ookinet, and then forms an oocyst. Then the oocyst ruptures and the sporozoites go and migrate to the salivary gland of the mosquito. And then, of course, this takes place in the midgut, the wall of the midgut. Then the complications, you could have from head to toe: cerebral malaria, acute pulmonary edema with respiratory distress, algid malaria, which is shock, acute kidney injury, black water fever, which is hemoglobinuria. You could have severe anemia, that's an HB that's less than 6, spontaneous bleeding and coagulopathies. You may have hypoglycemia, which is less than 2.2. You may have metabolic acidosis, which is a pH that's less than 7.25, bicarbonate concentration that is less than 15. You may have hyperparasitemia, you may have hyperpyrexia, and even the temperature may be actually greater than 39 degrees. Remember that in adults, jaundice is not a complication. Please do not go around telling people that I told you that jaundice is a complication. Jaundice is not a complication. Only in pediatrics, that's where we consider it as a complication in of severe malaria in pediatrics, according to Medscape. So question 21, study the image and answer the question. List 3 abnormalities. What is the most likely diagnosis? What is the underlying pathology? So here we have this person here. As you can see, one eye is closed. Their mouth is even deviated to one side. Over there, So most likely they have something that maybe could be affecting their facial nerve. So here they have loss of the wrinkles on their forehead, loss of the ability to completely close the left eye. Then of course there's a decrease of the nasolabial fold. The nasolabial fold is from the corner of your mouth, to the corner of your nose here. That's known as your nasolabial fold. So here there's a decrease in the nasolabial fold prominence on the left side, so on this side, and deviation of the lips. Of course, this is going to be seen in a facial nerve palsy, and this is most likely a lower motor cranial lesion that's affecting the 7th cranial nerve. Remember that here the rule of thumb is this: upper motor neuron lesion spare upper. So upper spares upper, lower spares lower. So it means if someone has an upper motor neuron lesion, they're going to be having problems in the upper face. If they have a lower motor neuron lesion, they're going to be having problems in their lower face. Moving on to station 22, study the image and answer the questions that follow. Describe the findings shown on the image. What is the name given to this? Mention 4 associated diseases. So again, another thing that you should have seen. If you haven't seen, then you may not know what it is. So this person has hypopigmented or depigmented patches of the skin. This is a condition that's known as vitiligo. It's an autoimmune condition where you get these antibodies that are going to be targeting the melanocytes and actually destroying the melanocytes. And that's why these different patches of the skin actually lose their pigmentation. And then the associated symptoms, you could have things like rheumatoid arthritis, you may have autoimmune thyroid disease, you may have type 1 diabetes mellitus, you may have psoriasis, you may have Addison's disease, SLE, celiac disease, and even some ulcerative colitis has been associated with SLE. Then again, back to our history taking questions. Someone comes in now with syncope, fainting, and you take a relevant history. Again, same schematic that we were using. The onset and the duration of the fainting, the frequency of the fainting, events that happened before, during, and after the faint. So some people can be doing certain things that can trigger them to fainting, especially if they have a special type of syncope, which is known as a vasovagal syncope, where, for example, someone is just in the toilet, they're pooping, and all of a sudden they're gone, they're fainted. Or someone is in the toilet, they're urinating, all of a sudden they faint. Okay? The position in which the patient was when they were fainting, it's very rare that patients actually faint when they're laying down. Very rare. So most of the times you get that they were walking, or they were seated, or they were standing. Then of course you get a collateral history about any abnormal body movements, because this could be a seizure. You want to distinguish this from a seizure. If there was any warning signs like dizziness, nausea, profuse sweating, if there's any precipitating factors like exertion, swallowing, even bowel movements, like I said, any associated symptoms like palpitations, tachycardia, panic episodes, and even hyperventilation that can actually trigger someone to faint. Then of course, you also get a family history of anyone having sudden death, because there are some people that just drop down and they die. And of course, you should also ask about drug history, your beta blockers, your digoxin, your antidepressants, your antiarrhythmic drugs, and of course a past medical history of diabetes, hypertension, ischemic heart disease, epilepsy, all those things. Make sure you ask about them, even a past history of them having a pacemaker, because sometimes arrhythmias can cause someone to faint. And of course a history of smoking and alcohol. Here's another picture on histology. So study the slide and answer the following questions. Describe the abnormality on the slide shown. What is the most likely diagnosis? What are the histological types of this condition? So this is another very, very characteristic thing. Okay, so this is a characteristic slide of Hodgkin's lymphoma. So you're going to be seeing these large cells that you're seeing here. As you can see, there's these giant cells which have this characteristic nuclei, which is known as an orphan Annie, or rather an RI nucleus. So these are actually what are referred to as Reed-Sternberg cells. It's like they're in a lake, they're in a lacuna here. These are known as Reed-Sternberg cells. So this is what we see in Hodgkin's lymphoma, and the types are going to be your lymphocyte rich, lymphocyte depleted, your nodular sclerosis, and your mixed cellularity. Remember that this is also one of the conditions that's going to be associated with HIV, especially type, or rather stage 4 HIV. Station 25, a patient presents to the emergency department with cough and fever. Take a history and ask the important questions. Again, I'm not going to waste much time on these questions on history because I've drilled you now, and it should be inculcated in you to ask this. So you should ask features about the cough, the age of the patient and the occupation, the duration of the symptoms, the nature of the cough. Is it productive? Is it non-productive? If it is productive, what's the color? What is there blood? Is there any sputum? Is there any presence of night sweats, any weight loss, any anorexia? Are there any other symptoms like chest pains, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea? Do they easily get fatigued? Is there any palpitations? Is there any leg swelling that's going to be associated? Then of course, ask for a history of TB, because this could be TB. Asthma, this could be asthma. COPDs, it could be COPDs. Hypertension, there's something that's known as cardiac asthma. I want you to look up cardiac asthma and what it is. Then, so drug history, family history of asthma as well, TB, as well as the history of smoking and alcohol. So Justin says that didn't manage to get a screenshot of 23. So here's the question for 23 in case you didn't manage to get a screenshot of that. So I shall just wait for like 2 seconds. And then here's the answer for question 23. I hope you managed to get a screenshot. I'll wait for a few seconds. Okay, so we can continue. So on this, here's another question. A patient presents with a swollen abdomen and parotid enlargements. I presume this is asking us to take a history as well. So same thing. Always think about the diagnosis that they're trying to lead you towards. In this case, this person is trying to lead you towards chronic liver disease, because these are features of chronic liver disease. Parotid enlargement is a feature of chronic liver disease, which is usually associated with some form of malnutrition. Then you also have some features that are due to, of course, estrogen excess. So things like pulmonary erythema, things like your maldistribution of hair, your testicular atrophy, your gynecomastia. Those are due to excess estrogen in the body. So you're going to be asking for the duration of the abdominal swelling. Do they have any swelling elsewhere? So do they have swelling of the feet, swelling of the face, yellowing of the skin, the eyes, the palms, if there's any fever, if there's any anorexia, is there any weight loss? Is there any history of hematemesis? Because remember that there are varices that can cause bleeding. Is there any history of them being in intravenous drug use? Because you're thinking chronic liver disease. What are some of the causes of chronic liver disease? Is there any blood transfusions? Do they bath in streams or dams? You're thinking schistosomiasis. Is there any hematuria? Then of course, the past medical history of HIV. Alcohol intake is very important. The duration, the amount, and the type of alcohol that they're taking. Then moving on to station 27, study the image and answer the questions that follow. What is shown in the image and what are the two variants? List 4 causes. So I'm actually planning to end this stream in 30 minutes. So in 30 minutes, we actually should be done with each and every single station. So as you can see on this here, we have this bluish discoloration of the fingers, the nail beds and the fingers. You can see this finger here is discolored. So this is obviously cyanosis. So you have peripheral cyanosis and you have central cyanosis. Now the causes of cyanosis are many. So you have your Raynaud's syndrome or your Raynaud's phenomenon, which I talked about, heart failure, hypovolemic shock, congenital heart disease, hypothermia, anything that will just cause hypoxia can present you with cyanosis. So that's one of the causes of, or one of the many causes of cyanosis. Then moving on to station 28, study the image and answer the questions that follow. What is shown in the image? State 2 common causative agents. State 1 drug used in the management of this condition. Is another nail sign. If you have, again, never seen this before, you have no idea what it is. So here, this person has this discoloration and thickening and separation of the nail bed. You can see that the nail bed is beginning to separate, or the nail is separating from the nail bed. So most likely this person has what is known as onychomycosis, which is a fungal infection of the nail. So these fungal infections of the nails are often caused by dermatophytes. So either Trichophyton rubrum or Trichophyton mentagrophytes. And then of course you're going to be treating this with your terbinafine, which is the drug that we use commonly, as well as your itraconazole. So terbinafine will just work very well. Then station 29, describe the abnormality in the image. What is the diagnosis? List 2 signs of this condition that you would look for. List 4 causes of the diagnosis above. List 2 diagnostic tests you would request for. So as you can see here, these nails look like a spoon. So this is what is referred to as koilonychia. So your koilonychia is pretty much your spoon-shaped nails. That's seen in iron deficiency. And the other features that the patient may have are things like your brittle nails. They may have brittle hair. They may have angular stomatitis. They may even have a bowed tongue, which is known as an atrophic glossitis. Now, causes of iron deficiency, anything that is going to lead to chronic blood loss. So it could be GIT bleeding, with the many different causes of GIT bleeding. It could be your hookworm infestation. It could be your menorrhagia. It could be your chronic illnesses. Anemia of chronic disease is also a cause of iron deficiency because there's a compound that's known as hepcidin, which is produced from the liver, which sequesters iron in patients who have chronic illnesses like malignancies, things like malnutrition, things like malabsorption, even chronic kidney disease. Then, of course, 2 diagnostic tests you can order for your iron studies, where you check for your serum iron, your ferritin, your transferrin, your total iron binding capacity. I'll put out a lecture sometime. I don't know if it will be relevant for those that are taking exams, but I'll put out a lecture on anemia to discuss this in much greater details. Then, of course, we also want to do our endoscopic studies, so your endoscopy and your colonoscopy. Then, of course, you can also order for a full blood count. Here's a sidebar. This is what leukonychia looks like. Remember leukonychia? Common in hypoalbuminemia and liver diseases. This is what leukonychia looks like. They can sometimes bring you this on your exams. They appear white. Now, station 31. What investigation is shown in the picture? What pathology is it showing? What risk factor causes this condition? So this here is obviously a computerized tomographic scan. For those that don't know what CT scan actually stands for, it stands for computerized tomographic scan. Now, this is a CT of the head. Now, what do we see on this CT scan? Remember when I told you, if the lesion is appearing darker than the brain tissue, we should refer to it as a hypodense lesion. So this is a hypodense lesion of the right cerebral hemisphere, because this is the right side, this is the left side, this is anterior, this is posterior. So here you have a right-sided hypodensity. As you can see, even these are ventricles. The ipsilateral ventricle is compressed. You can see that on this side, you can tell that there are these spaces that you can tell. These spaces that you see are known as sulci. So there is differentiation of the sulci and the gyri in the brain, which is known as the corticosulci differentiation. You're supposed to be able to see those spaces. But if you notice on this side, you can't really see those spaces. You call that as a corticosulci effacement. It's like the sulci have now been obliterated. So this is consistent with an ischemic stroke. Now, the risk factors of ischemic stroke, 2 most important things: hypertension, diabetes. You could have other things like smoking, atrial fibrillation, anything that can predispose a clot from forming. Mechanical, even prosthetic heart valves, valvular pathologies, hypercoagulable states, family history, even sickle cell disease, even a history of a stroke can present to you as a risk factor for having a stroke again. So sidebar, this is what a hemorrhagic stroke looks like. So this here, blood is also going to be appearing. If it's acute blood, fresh blood, it's going to be appearing bright, okay, whitish like this. If it is subacute, it will almost now be appearing like the brain consistency. If it's chronic, it's a bit darker. Now it's a bit difficult now to distinguish a chronic hemorrhage from an ischemic stroke. So I want actually the 7th years to be able to distinguish. I want you to read up on how you distinguish a chronic hemorrhage. I mean a chronic hemorrhage, yeah, from an ischemic stroke. How would you differentiate that on a CT scan? So station 32, a 19-year-old is brought to the emergency department due to confusion, difficulty with arousal from sleep. He also has generalized headache, neck stiffness, muscle aches. Temperature is 39 degrees Celsius. BP is 102/68, pulse is 107, and respiratory rate is 22. On physical examination, there is a petechial rash, and of course this is extending the thorax, it's extending the extremities, and when supine and the neck is flexed, there is involuntary knee flexion. This is known as the Brudzinski sign. Okay, remember the opposite to this is known as the Koenig's sign. So this is known as the Brudzinski sign. Then what diagnosis are we going to actually look at here? So remember, these are known as petechiae. Okay, whenever you have petechiae, it means that this person has some problem with their primary hemostatic system. Okay, because remember that injury to the endothelium, problems with the platelets will result in what is known as a primary hemostatic disorder. So most likely this person has injury to the endothelium. This is very common in gram-negative infections. Most gram-negative infections will give you this. Now this patient is presenting to you with features of meningitis. So what organism is causing meningitis that can present you with these features, such as these petechiae? There's only one organism that comes to mind. That's your Neisseria meningitidis. So that this person has your meningococcal meningitis. So it's caused by a gram-negative coffee bean shaped diplococci, and of course it's going to be transmitted through respiratory droplets, inhalational method. Now moving on to station 33, describe the lesion. What is the most likely diagnosis? List 3 musculoskeletal features of this condition. Another one such pathognomic thing that you can actually pick up when you just look at the pictures. So this is known as a butterfly malar rash. So it's shaped like a butterfly over there. So this is shaped like a butterfly. This is seen in systemic lupus erythematosus. Remember, do not write abbreviations. Systemic lupus erythematosus. So the 3 skeletal manifestations could be arthritis. This is one cause of non-erosive polyarthritis. It can cause tenosynovitis, that's inflammation of the tendons and the capsules that are surrounding them. It can cause myositis. Moving on to station 34. This is probably even the X-ray of that X-ray that I showed you about a COPD. You can see now that this is now characteristically showing you now that barrel-shaped chest that we're having. So this patient here most likely has your emphysema or your COPD. So this person here has this barrel-shaped, the hunched back. This is known as a kyphosis. Okay, so they have a kyphosis of the thoracic region, and they have a barrel-shaped chest, so an increase in the anterior posterior diameter. This is very consistent with COPDs. We see it in asthma patients, especially if they've had it for a very long time. We see it also in a condition that's known as ankylosing spondylitis. Now the investigations that we want to do, of course, we want to order for a chest x-ray, we want to order for sputum analysis, we want to do an ECG, of course, like I told you, core pulmonale earlier on, and we also want to do our arterial blood gases. I think this was a repeated station. I covered the station below. It was the total lung collapse, so I won't waste time on the station. Okay, station 36. We have a male, 42, HIV positive, with headache, weight loss for 3 weeks. He last took his ART 2 years ago. He is confused, wasted, he has oral thrush, and you note painful lesions on his face. Comment on the skin lesions. What is the differential diagnosis of the skin lesion? What is likely the complete diagnosis for his presentation? What 4 cardinal investigations, not procedures, would you order? What drugs are used to treat the diagnosis in part 3 above? Name any 2. So now, if you zoom in closely into this image, let me just zoom in into this image. You can see that this here looks, it's a rounded elevation. This is a rounded lesion. Most likely this looks like a papule. And it has a dot. You can see that if you increase the resolution, there's a central dot here. It's umbilicated. It's like it has an umbilicus. So this is very, very characteristic of a condition that's known as Molluscum Contagiosum. So this person has umbilicated brown papules. This is seen in Molluscum Contagiosum, but it can also be seen in coccidiomycosis. It can be seen in cutaneous cryptococcosis. It can be seen in cutaneous histoplasmosis. Now, for the diagnosis, most of the times students tend to make a very, very huge mistake on diagnosis. They do not give full diagnosis. So someone, let's say you're marking 2 papers as an examiner. On one side, a student has just told you Molluscum Contagiosum. That's it, they're forgotten and they're okay with it. Another student tells you Molluscum Contagiosum in an RVDR patient, WHO, stage 3, because this patient is wasted and they have oral thrush. Oral thrush is a stage 3 condition. Who are you going to give more marks? This one who just said Molluscum Contagiosum and forgot, or this one who gives you the full diagnosis? So you should always strive to actually have a full diagnosis when you look at your patient. Look at something that covers everything that the patient has. So the investigations that you want to order, of course, your CT scan of the head, CD4 count, your viral load, and you can do a lumbar puncture. If the CT scan has cleared that there's no space-occupying lesion. Of course, the drugs are your HIVs, so you can use any of the HIV drugs that you know. That's your zidovudine and lamivudine. Now, moving on to station 37, a male, 57, known diabetic and hypertensive for 6 years, unknown HIV status, developed abdominal fullness, but no pain a month ago. Developed leg swelling, both legs 2 months ago, and noticed the face was puffy in the morning and the urine was frothy. So the puffy face and frothy urine should give you something in your mind. It should tick something in your mind. So he has associated gradual increasing shortness of breath with no chest pains, and he developed spontaneous bruising over the past 5 months. What is the likely diagnosis? What investigations will you do? And give the findings you expect for each test. List 4 possible causes. Now, whenever you see someone waking up and their eyes are puffy, their face is puffy, they are swelling, this is how I want you to now think of edema from now on until the day you die. If someone has any swelling in their body, it could mean one of many things. Number 1, it could mean that there's a problem with their heart. Okay? Usually, if there's a problem with their heart, there are also other symptoms that are going to be associated. Things like exertional dyspnea, orthopnea, your paroxysmal nocturnal dyspnea, but the heart failure can present to you with edema. It could be a problem with their liver, because remember that the liver is going to be producing these proteins that are going to be maintaining the oncotic pressure inside the bloodstream to prevent fluid from leaving the bloodstream. So it could be due to your oncotic pressure falling down, meaning that your liver is not producing the proteins, or you're not taking enough protein. So it could be a malabsorptive syndrome. That's where you can even put malnutrition. Or you're losing the proteins. It could be a protein losing enteropathy. So, like for example, the problem with their stomach and their gut, and they're losing these proteins in their stool. Or it could be that they are losing the proteins in their urine, which is your so-called nephrotic syndrome, which is what is described here. And what is characteristic of renal disease is that it starts off with puffiness around the eyes. Now you may ask, why is it around the eyes? It's because the tissues around the eyes are very loose. So that's where most of the fluid actually accumulates. During the day, as you now get up and you start walking about, the edema goes down because this is actually going to be moving down to the gravity-dependent position, so to the lower parts of the body. So, you have your nephrotic syndrome. So the investigations that you do, what you may do long ago, if you read a book that was printed way back, they'll tell you that the gold standard of making a diagnosis of nephrotic syndrome is doing your 24-hour urine collection test, where you get your proteinuria that's greater than 3.5 grams per day. But that's no longer the gold standard. They're actually much more accurate things like your urine albumin to creatinine ratio. If it's greater than 250 milligrams per millimole, then that's diagnostic of nephrotic syndrome. If you can also do your urine protein creatinine ratio, if it's greater than 300 nanograms per millimole, then that's indicative of nephrotic syndrome. Just simply comparing the ratio of the amount of albumin in urine to the ratio of the amount of creatinine. Then you may sometimes order your serum albumin, which may be decreased, your lipid profile. So things like your decrease in cholesterol, your triglycerides, your LDLs, and your HDLs. Then of course your chest x-ray may show a pleural effusion. Your renal biopsy for microscopy, histology, and histochemistry. Then, of course, 4 possible causes of nephrotic syndrome. It could be hypertensive nephropathy. It could be diabetic nephropathy. It could be that this patient has systemic amyloidosis. This person could have the SLE. They could have infections like malaria, EBV, HIV, hepatitis B, even hepatitis C virus. And of course, next station, a 45-year-old patient presents to the outpatient department with yellowing of the eyes for 7 days. Focused history, so we're not spending time on this. I think you guys are now certified experts at history. If history questions, if you get 2 history questions, at least I can sleep tonight and know that the people that are watching this video are going to go to bed and they'll at least have 2 stations out of how many ever stations you're going to be writing for your exam. Okay, so yellowing of the eyes, residence, country of origin, you're looking out for hepatitis B, malaria. Symptoms that are going to be pointing you towards obstructive jaundice, so things like pale stool, itchy skin, dark urine, pointing you towards obstructive jaundice. And of course, the stool can sometimes be fatty, very difficult to flush if they have a flushable toilet. If they have had any recent sexual activity, it could be hepatitis B infection. Any blood transfusion, you're thinking hepatitis B or C. Any tattoos, any piercings that they got recently. If they take alcohol, the type, the amount, and the frequency, because this could be alcoholic liver disease. The drugs that they're taking, there are many drugs that can cause jaundice. Many drugs are hepatotoxic. The TB drugs, for example, are hepatotoxic. Then any recent surgery that they had on the biliary system, or if they've had any surgeries for any carcinomas, if they've had any recent travel in cases of hepatitis A, hepatitis E, malaria, and even if they have any features of melena or hematemesis, which are features of chronic liver disease where they are bleeding from their GIT. Then station 39, a 22-year-old male HIV patient is found to have a large right-sided pleural effusion. The left side of his chest is normal. Outline the findings you will get when you do a chest examination on this patient. List 3 causes of a pleural effusion. Again, make a template in your head of this. I've given you a template for history. Now I want you to make a template in your head for examinations. Whenever you're doing an examination, think of it like as if you are there examining the patient. So remember IPPA, inspection, palpation, percussion, auscultation. Once you do this, you ask yourself, what do I expect to find if a patient has a pleural effusion? When I inspect, the same thing can be used for, of course, your ascites or any other examination that you're told to do. So on inspection, of course, because now there's fluid accumulating on one side, it can push the structures to the other side. So it means that even the trachea will be pushed to the other side. There may be asymmetrical chest expansion when you observe this patient. Now, the side where the trachea has been pushed towards, the sternocleidomastoid, which is this muscle, where when you turn your head to your left, this muscle, the sternocleidomastoid muscle, tends to stand out on that side. So you call this as a trail sign. And of course, you may have features of respiratory distress, so things like use of accessory muscles, nasal flaring. You may have things like subcostal, intercostal recessions. Of course, when you palpate them, the trachea will be deviated towards the left. Okay. Then, of course, they will also have decreased tactile fremitus on the right. Then on percussion, they'll have stony downness on the right because they have a fluid that's accumulating on the right side of their chest. And of course, when you examine the right side, there will be a decrease in air entry on the right side, reduced vocal resonance. 3 causes, it could be mesothelioma, which is a tumor of the pleural cells. It could be a nephrotic syndrome. It could be congestive heart failure. It could be Meg syndrome. So Meg syndrome is a condition where you have 3 things. Number 1, you're going to be having a right-sided pleural effusion. Number 2, you have ascites. Number 3, you have an ovarian tumor. Then, of course, it could be, pneumonia. Then station 40, what pathology is shown in the X-ray? List 4 differentials of the above. 4, what is the most common causative agent for this picture in our environment? List the sites that can affect or that can be affected in the body. So as you can see here, you have this bilateral miliary shadowing. That's what you should refer to it. Bilateral miliary shadowing. It looks like tiny stars. So this is, of course, most consistent with miliary TB. So miliary TB could be a cause: histoplasmosis, sarcoidosis, pneumoconiosis. even pulmonary siderosis. All those things can cause a miliary picture. Mycobacterium tuberculosis and miliary TB are by far the most common cause in our setting. Then remember, TB, especially miliary TB, can affect virtually any organ. So it can affect the meninges, it can affect the brain, the spine, the bones, the spleen, the lymph nodes, the pericardium, the liver, the kidney, the abdomen, and even the peritoneum. Remember, if you get a biopsy of any of these organs and you look at them under the microscope, sometimes people surprise me because you have learned these things at 4th year. They ask you, what are you going to see when you get a biopsy of a lymph node for TB? Obviously, you're going to be seeing your granulomas. You're going to be seeing your caseous necrosis. So don't forget the basics that you learned at 4th year. Don't forget the basics that you learned at 3rd year. So question 41. A 65-year-old man presents to the cardiologist for a checkup over the past 2 years. He has developed significant shortness of breath with exertion and easy fatigability. He has a past medical history of hypertension and coronary artery disease. On cardiac examination, there is a diastolic decrescendo murmur, bounding peripheral pulses. The physician also notices head bobbing. What is your diagnosis? What gold standard investigation are you going to do for him? List 4 other peripheral signs this patient can present with. What is the commonest cause of this diagnosis in developing countries? Now, here's murmurs again, which gives students a lot of hell. Now, I've made murmurs very simple. I've done a video on murmurs. So after this live stream, if you are still confused with murmurs, please head over to internal medicine folder. Have a look at heart sounds and murmurs. I've explained that very well. Once you listen to that, I've actually even added sounds to that of how the murmurs sound like. It's very easy for you to learn. Then, of course, here, first of all, let's look at what this person has. They have a diastolic murmur. Remember, whenever you're thinking of a diastolic murmur, in this case, you're thinking that this is a problem that's going to be affecting either the closure of the aorta or the pulmonary valves, or it can be affecting the closure of the mitral or your tricuspid valves, or rather the opening of the mitral or tricuspid valve, not closure, opening of the mitral and tricuspid valve. So it means that mitral stenosis, tricuspid stenosis will give you diastolic murmurs. Aortic regurgitation, pulmonary regurgitation are going to give you diastolic murmurs. So they are all diastolic murmurs. The things I've mentioned are all diastolic murmurs. Then, of course, this here is going to now present to you as there's a characteristic murmur that we see in aortic regurgitation, where there's an increase. There's a decrease in the intensity of the murmur. If you watch the video, I'll play it for you, and it's well explained. So this, most likely, this person here has aortic regurgitation. So remember that this person has acute aortic regurgitation in a non-hypertensive patient. Remember that whenever you make a diagnosis of hypertension, it must always have a functional classification. So it must always have a New York Heart classification. Remember your New York Heart classification, you have your class 1, class 2, class 3, class 4. This patient is a class 3 because they are significantly having symptoms with minimal exertion. Then remember, class 4, they have symptoms at rest. The gold standard is, of course, your echo. The other signs are many signs of aortic regurgitation. You may have visible carotid pulsations. We call that as a Corrigan sign. You may have nodding of the head like a bubblehead. Those things that you keep in a car, a bubblehead. Then you call that as Demusset sign. You may have capillary pulsations in the nails. You call that as Quincke sign. You may have even pulsations of the uvula. You call that as a Moeller sign. Now, the most common cause previously, before we had antibiotics, it was rheumatic heart disease. Now, currently, the most common cause is bacterial endocarditis. Here's another one for ECG station. So what is shown in the ECG? What is the diagnosis? List 3 possible causes of this ECG. So I'll just go through the answers. I won't spend much time because I've given you the basics of how to read an ECG and how to go through an ECG. So this person here has an irregular rhythm. That's a very, very tongue twister. It's a potential thing to mess yourself up. So as you can see here, this distance from here to here on your screen is not the same from here to here. It's not the same from here to here. As you can see, there's no rhythm. The space in between the RR intervals is not the same. It variates. So they have an irregular rhythm. If you look very closely, now, if someone has an irregular rhythm, this is how we determine the heart rate. On this rhythm strip, I want you to count 30 big boxes. Okay, you count 30 big boxes. Suppose from here to here, it's about 30 big boxes, yeah? Then in these 30 big boxes, you count the number of ECG complexes, the QRS complexes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. But in this case, they came up to 14. I haven't yet counted. I just estimated that it ended there, but there are about 14 QRS complexes. Then you multiply that number by 10. That gives us the approximate heart rate. The cardiac axis here is normal because this is facing upwards. This is also facing upwards. ST segment, there is some ST segment elevation, especially in V2 here and in V3. And there's a poor RS wave progression. I explained that much earlier on about the RS wave progression. So this is seen in atrial fibrillation. So this is atrial fibrillation with a rapid ventricular response. It's seen in ischemic heart disease, it's seen in pericarditis, it's seen in COPD. So take your time to have a look at this ECG and master and see if you can actually translate what I've seen, what I've shown you on the answers to what is actually showing up on this. So I think I will upload this PowerPoint presentation to my Dropbox, and I'll actually leave a link in the community tab on my channel so that you can actually download this PowerPoint and actually revise using this PowerPoint. So station 43, during a major ward round, you notice the following findings on the patient's abdomen you are told to examine. Abdominal distension with an obvious mass in the left upper quadrant. What organ could be enlarged? What would cause this organ to massively enlarge? Your consultant asks you to justify why this organ is not something else. Give a reason. Remember what I was telling you about when we were examining the liver? They can sometimes ask you about the spleen. So you should put your mindset in this fashion of now being the examiner and seeing what can the examiner ask me? What are the alternative things? So most likely this person here has, it's a spleen what is being examined. This person has splenomegaly. Remember, China mobile phones suck as your mnemonic. C for CML and CLL, so chronic myeloid leukemias, chronic lymphoid leukemias. H for hairy cell leukemias. I for infections like malaria, EBV, CMV. L for lymphoma. Then autoimmune for autoimmune hemolytic anemia. China for N for autoimmune hemolytic anemia. Then mobile for myelofibrosis. Phones for polycythemia. Then of course SAC for sarcoidosis. So those are the causes of massive splenomegaly. Not just splenomegaly, but massive splenomegaly. Remember I told you that the spleen is going to be growing towards the right iliac fossa in a diagonal fashion, and it's going to be down to percussion in that area. You can't go above it, you can't go below it, and it has a notch. That's how you know that this is a spleen and not anything else. You conduct a urinalysis and find protein 3+, nitrates negative, leukocytes negative, bilirubin negative, glucose negative. Give 5 such causes of such results. So these are causes of proteinuria. List the test you would do to ascertain a cause. So most likely nephrotic syndrome can cause proteinuria. That's the most common cause. Preeclampsia and eclampsia can cause proteinuria. Chronic kidney disease can cause proteinuria. Multiple myeloma can cause proteinuria. Congestive heart failure can cause proteinuria. Dehydration and even diabetes can all cause proteinuria. So these are just some of the important causes of proteinuria that you really need to take note of. The test that we're going to be doing is serum urea, electrolytes, creatinine, to monitor the function of the kidney, because this patient could be in chronic kidney disease. Your fasting blood glucose to of course rule out diabetes, and your random blood glucose. Your abdominal ultrasound to rule out chronic kidney disease. Remember that the kidneys actually tend to shrink in if it's a chronic type of kidney disease. You can get a kidney biopsy as well for the different nephrotic syndromes. Then a chest x-ray, an ECG, and an echo as well. So station 46, a female 42-year-old patient came in with hair loss and hand lesions as shown. She also has joint pains and fatigue. You suspect a diffuse connective tissue disease. What is the most likely diagnosis in this patient? What lesions are in her hands? give one disease-modified anti-rheumatoid drug or DMARD you would use if this lady wanted to conceive in the near future. Okay, so most likely these lesions are what we call as this patient most likely has SLE. Why do I say SLE? Because they have this alopecia that they have, and they have this rash which is roundish in size. It's like a discoid rash. Some people may argue that this look like petechiae, so I want to actually get your opinion about whether this look like petechiae or discoid rash. Just have a look at the image. I'll put that in the Dropbox, and I'll put a link on my community tab. Before you actually leave, don't forget to drop a like on this video to show your support. Then of course we want to use drugs like sulfasalazine and hydroxychloroquine in the treatment of this condition. Most people could also argue that this patient could have rheumatoid arthritis, because that's a diffuse connective tissue disease, so they could have rheumatoid arthritis. Okay, so I'll leave that up to you to decide whether it's between SLE and rheumatoid arthritis. Then station 47, what is the clinical sign shown in the image? What is the diagnosis? List a differential diagnosis based on the image. What 2 tests would you do to confirm the diagnosis? Mention 1 drug that is used in the treatment of this condition. What advice would you give this patient who keeps presenting to the hospital with severe pain despite you giving this prescribed drugs? So now these are tophi. Okay, so this is tophaceous gout. These are tophi, depositions of uric acid crystals. So one differential that you should keep in mind is rheumatoid arthritis, because they could be rheumatoid nodules. So you should order for your serum uric acid, a joint aspirate, and also an x-ray of the parts. The drugs that you can use could be colchicine, allopurinol, even febuxostat. Then of course, if this patient keeps presenting with this condition, you tell them to lose weight. You tell them to reduce their purines in the diet. So alcohol should be cut out. Some fish like sardines, anchovies should be cut out. Trouts, meat should be cut out. Bacon should be cut out. Turkey and even liver should be cut out, because they have a high concentration of purines, which are pretty much going to be used now to make the uric acid which deposits in the joints and the tissues. Then outline the respiratory findings you would elicit in a patient who has a large pneumothorax on the left side. List 3 causes of a pneumothorax. So this, again, IPPA, inspection, palpation, percussion, auscultation. So on your inspection, asymmetrical chest expansion, very similar to your pleural effusion, but there is some difference. Trail sign this time on the right side, because this is happening on the left side, so it's pushing the contents to the right side. So trail side on the right side. You have features of respiratory distress, so you have use of accessory muscles, your tracheal deviations, your asymmetry of the chest, and of course your reduced tactile fremitus on the left side. And then on percussion, you get a hyper-resonant note. Remember, in a pleural effusion, we had a down note. Then of course, auscultation, you have a reduced air entry. Then of course, 3 causes of pleural effusion: chest trauma, which is penetrating. I mean pneumothorax, not pleural effusion. Chest trauma, which is penetrating. Malignancies like mesotheliomas. Rupture of the subpleural blebs. You can sometimes have mechanical ventilation. Some iatrogenic causes, like for example during the placement of an ICD. Those are some of the causes of your pneumothorax. Then station 50, we're almost concluding and we're almost done with the stations. Describe what you see in this picture. List 4 respiratory causes of this condition. List 3 gastrointestinal causes. List 2 cardiovascular causes. So this is most likely finger clubbing. Okay, interesting thing, the grading of finger clubbing was actually described by a South African person, so it's actually an African thing that has finger clubbing. They have a drumstick appearance of their fingers. So the respiratory causes are many. So you have things like COPDs, lung fibrosis, bronchiectasis, lung cancers, pulmonary TB, mesotheliomas, even empyema. Think anything that can lead to hypoxia. Then of course the gastrointestinal causes: chronic liver disease, inflammatory bowel disease, even celiac disease. And then of course your cardiovascular diseases like your cyanotic congenital heart diseases, your subacute bacterial endocarditis, even your left atrial myxomas. Then station 51, a male 53 presented with the history of fever, sweats, abdominal pain, and constipation. Identify the abnormality on the chest x-ray. What is your differential diagnosis? What resuscitative measures do you undertake? What is the definitive measure or definitive management? Sometimes people often surprise me. Why do they surprise me? They've given you a typical history. They've literally given you the answer on the plate. That here you go, here's the answer, and you completely ignore it. They've even gone to the extent of even pointing you towards the pathology and giving you these 2 arrows here to point you that the problem is here. So this is known as your double diaphragm sign. Most likely there was a perforation in this case. Now, this is a double diaphragm sign. So air under the diaphragm, and this is indicative of pneumoperitoneum. So this is an intestinal perforation. It could be secondary to, for example, typhoid fever. In this case, this person had fever and night sweats. In retrospect, actually, this could be secondary to TB. Okay, TB abdomen. Then, of course, they could have intestinal perforation secondary to intestinal obstruction as well because they have some constipation. Then your measures, of course, your ABCs, do not write ABCs. They mean nothing in your exam. Write them in full, what exactly you're going to do. Cannulate the patient and run IV fluids. Insert an NG tube to decompress, and then insert a urinary catheter. And then the definitive management is surgery. You should cover them on IV antibiotics. Here is another sign of koilonychia. I think we looked at it, but this is now with the feet. So this is koilonychia. This is affecting the feet now. Iron deficiency. We've talked about the different causes of iron deficiency. Nutritional causes, it could be due to increase in demand like pregnancy, chronic blood loss like a chronic GIT, bleeding, hookworms, malignancies, even chronic diseases, and even some malabsorptive syndromes. Then station 53, describe the pathology shown in the chest x-ray. What is your diagnosis? What is the most likely causative organism causing this pathology? List any 3 complications of the disease entity. Again, this is a homogeneous opacity. It's completely white. If you look very closely here, there appears to be like some dark lines that you can see within this homogeneous opacity. You call this as air bronchograms. So you have this right-sided upper lobe homogeneous opacity with air bronchograms. We can't see the right side of the heart here, so you call that as a silhouette sign of the right heart border. So this is consistent with a lobar pneumonia, a right-sided lobar pneumonia. Most commonly caused by your Streptococcus pneumoniae. Complications can be grouped as local, where you have things like empyema thoracis, parapneumonic effusions, you may have lung abscesses, you may have distant complications like your septic arthritis, your meningitis, and even your core pulmonale. Then of course your drug of choice is going to be your penicillins, but you can also use your cephalosporins, but penicillins tend to respond much better. Here's station 54. A 45-year-old man presents for routine HIV clinic. He is on combined antiretroviral therapy for 4 years on first line. On physical examination, you notice something on his chest. Name the clinical sign. What is the cause of the clinical sign in this patient? What are the causes of the condition in the general population? So this man here has enlarged breast tissue. This is known as a gynecomastia. You don't call it gynecomastia in females. Gynecomastia is only a term used for males. I should never see you saying a female has gynecomastia. No. Okay. So this is most likely due to the ARV. Nevirapine has been known to cause gynecomastia. Then other conditions include things like liver cirrhosis, aging. You could have obesity, hepatocellular carcinomas, hormonal replacements, especially with estrogen. Then drugs like spironolactone, even finasteride. In some cases, in patients, just a sidebar, in patients that have testicular tumors, in male patients, you should order for a pregnancy test. Why am I saying for a pregnancy test? Because the tumors can sometimes produce beta HCG. So just keep that in mind. In the corner of your mind is just one of those facts that you may find useful on one of the stations on your exams. Who knows? Now, station 56. Study the image and answer the questions that follow. Describe what you see. Mention 5 related causes. So as you can see, the image is over here. So this person here has a globular abdominal distension with flank fullness. The umbilicus is inverted. As you can see here, there are even some distended veins that you can see on the surface. And generally, this patient also looks yellow. To me, this person looks yellow. The skin looks yellow. So this is most likely a liver cirrhosis or chronic liver disease. You see it in heart failure. You can see ascites in heart failure. You can see it in peritoneal carcinomatosis, where a tumor spreads to the peritoneum. You can also see it in nephrotic syndrome. You can see it in pancreatitis. Moving on to station 57. So study the image and answer the questions that follow. So describe the lesion. What is your diagnosis? State the causative agent. What are the variants of this clinical condition? Again, this is another thing. If you have seen it before, you have an idea of what it is. If you don't know what it is, then you obviously don't. So these lesions here are purple or dark papules. So this is like a papule here. You can have plaques. You can sometimes have patches which are flat. Then underneath here, you're going to be having your purple papule, which is this one here. You can also have this patches here, the purple patches. This is characteristic of Kaposi sarcoma. This is seen in Kaposi sarcoma. It's caused by human herpes virus 8. And the variants, there are 4 of them. You have the classical type, which is also known as the sporadic. You have the African cutaneous type, which is also known as the endemic. We have the AIDS associated, which is known as the epidemic. And we have the immunosuppression, which is known as the iatrogenic. Okay, those are the types. Then the things that you see on histology, just a brief before I actually continue. The things you see on histology, you see your spindle-shaped cells, extravasated red blood cells, and prominent slit-like vascular spaces. Those are the 3 features that you see that are pointing you towards Kaposi sarcoma on histology. Then study the image shown and answer the questions that follow. Describe the findings on the X-ray. What is your diagnosis? What are the principles of management? This is similar to the X-ray that I showed you a few slides ago. So this person has a homogeneous opacity of the right upper lobe limited by your horizontal fissure. This is also a right upper lobe pneumonia. So we admit the patient, we cover them on antibiotics, we give them oxygen, we cover them on IV fluids. Any patient with a respiratory illness, remember every time you increase the respiratory rate, you're breathing out pretty much air. You're breathing out water vapor, so you're losing fluids. So adequate nutrition is also important, as well as your chest physiotherapy. Then study the image and answer the question. So describe the lesions, what conditions associated with the pathology, what is the most likely diagnosis, outline your management. So these are whitish lesions that you can see, whitish patches you can see on the palate and around the mouth. So this is your oral thrush or your oral candidiasis. These conditions that predispose an individual to this, think of immunosuppression, HIV and AIDS, which is the most common cause in our setting, diabetes, and even cancers. The treatment is, of course, treating the underlying cause. Then, of course, we give them oral antifungals. That's your fluconazole, which we can give as 200 milligrams as a start dose or 100 milligrams once a day in these patients. Then, station 60. Study the image and answer the questions that follow. Describe the lesion, list 4 differentials. So here's the lesion here. So most likely this is a small linear splinter hemorrhage in the subungual. This region here is known as the subungual area of the left thumb, and it's running parallel to the long axis of the nail. So this is seen in infective endocarditis, it's seen in vasculitis, it's seen in nail psoriasis, it's seen in rheumatoid arthritis, it's seen in lupus. Okay. Station 61, you told to examine an abdomen, a patient with ascites. You see what I was telling you about? If you now change your mindset to the examiner's mindset, you are able to now even predict what your examiner is going to ask you. Osce stations are very easy to pass, especially the projected ones. Just think like the examiner. And whenever you're answering your questions, never assume that the examiner knows. Answer it in a way that you're teaching the examiner. That way you will get the best of both worlds. So you list the findings you would elicit during examination. Remember your IPPA. Give 5 differentials. So on your inspection, you get your round, symmetrical, distended abdomen with flank fullness. You get protruding or displaced umbilicus. You may get dilated superficial veins. You may get abdominal striae. On your palpation, you're going to get this doughy feeling of the abdomen. It feels like dough, flour with water. Then, of course, if it's advanced, it's going to be tense. On percussion, you have periumbilical tympanic sound, but then on the flanks, there may be some downness. You may have a positive fluid thrill. You may have a positive shifting downness. Now, causes could either be if you have a normal peritoneum, meaning that these are rather transudative causes. So things like congestive heart failure, Budd-Chiari syndrome, liver cirrhosis, things like nephrotic syndrome, protein losing enteropathies, tricuspid regurgitation. Remember those things that I told you about, the heart, the kidneys, the liver. Or it could be a problem with the peritoneum, an inflammatory condition or a malignancy. So it could be a peritoneal carcinomatosis. It could be primary mesotheliomas. It could be hepatocellular carcinomas and even TB peritonitis. Station 62. A female 32 years old with abdominal pains, weakness, palpitations for 2 weeks. On investigation, she has an HB of 8 and the organism in the picture was noted. What organism is shown in the picture? Give the 2 main species that cause disease in men. Give a brief life cycle. What are the risk factors? So these worms here, again, if you haven't seen them, you wouldn't know. These are known as hookworms, or you can call them as helminths. So there are 2 important species. You have your, you have your Ankylostoma duodenale, you have your Neicata americanus. Then the difference is that your Neicata americanus has these cutting plates. At its mouth, it has these cutting plates. So the life cycle is this. So you get these filarial larvae, which are going to be found in moist soil. So whenever you're walking barefoot in soil, this can now penetrate into the skin, and they can be carried in the bloodstream to the lungs. Kind of similar to what we had with the other hookworm we talked about, Ascaris lumbricoides. They migrate to the alveoli, then they move to the bronchi, they move to the trachea, then they're going to be swallowed. And then they're going to develop as an adult in the intestines. They will attach to the walls of the intestines. Remember that if it's Neicata americanus, it has these cutting plates. Ankylostoma duodenale has teeth. Then, of course, they start feeding on your blood vessels, your capillaries, and, of course, they lay eggs, 1,000 of them a day, which can sometimes be passed on. And then the eggs will develop into a non-infectious form, which is known as a rabidiform. Then, of course, these rabidiform larvae are going to penetrate the skin to complete the cycle. Then, what are the risk factors? You have walking in barefoot, especially in moist soil, poor personal hygiene. Even sanitation is a huge risk factor. This is another case of Kaposi sarcoma. In this case, they're showing you lesions now on the skin. So here they are purple violaceous patches. They are flat. Patches are flat. Nodules are raised. This is Kaposi sarcoma. The 4 types we talked about: classic or sporadic, African cutaneous, which is also known as endemic, AIDS associated, which is also known as epidemic, your immunosuppressive, which is known as the iatrogenic. Then, of course, on your histology, like I told you, you're going to be seeing your skin biopsy. You're going to be seeing your prominent spindle-shaped cells, your prominent slit-like vascular spaces, and your extravasated red blood cells. Those are the things that you're going to be seeing on your histology. Then one important differential diagnosis is, of course, your bacillary angiomatosis. It could also be a small vessel vasculitis. Then question 65, of course, we're in the COVID era, so expect to see something that looks like COVID. So on 25th of January 2021, a male 65 presents with a fever, cough, muscle aches, fatigue for 4 days. He is hypertensive, he has diabetes, and not HIV. Oh, is not HIV positive. Chest x-ray shown here. So comment on the chest x-ray, list 4 cardinal tests that you're going to order. What are the possible differentials? What is the most likely diagnosis? Name 1 physical feature that is associated with poor prognosis in these patients. So if you can see this x-ray here, you can't really, it's like as if it's a bit hazy. You can see like there's something going on here. At the same time, you can still see the lung. So you call this hazy-like appearance as what is known as your ground glass appearance. So you have this ground glass appearance affecting the lower zones of the lungs bilaterally. The cardiothoracic ratio is normal. The trachea is central. And of course, you can visualize the pleural membrane on the left side. On this side, you can visualize the pleural membrane, this strip here. Okay, and because there is also absent of lung markings, you'll see this very closely when I give you the PowerPoint. Then, of course, this you would want to do your viral nucleic acid detection, or your PCR, your D-dimers, your sputum microscopy culture sensitivity, GeneXpert for TB, and then if you're one of those people who like forcing things, full blood count. Then the possible diagnosis, of course, it could be your COVID-19. COVID-19 will give you a characteristic X-ray like this one. Or it will be your multifocal or your viral type of pneumonias. Then, of course, age above 65 is one poor prognostic factor. If they are desaturation, if they're desaturating, it's a poor clinical factor. If they have dyspnea, it's a poor clinical factor, prognostic factor. Now with the labs, if you get high D dimers and a high ESR, that's usually also a poor prognostic lab factor. Question 66, what deformity do you see in the right hand? What deformity do you see on the left hand? So on the right hand here and on the left hand here, these deformities are different. In which condition are these signs seen? List 2 variants that the diagnosis has. List 5 extra-articular manifestations. So this here that you see here on the right hand here, this looks like the neck of a swan, where you have a flexion here that's affecting the distal interphalangeal joint. So this is known as a swan neck deformity. Then here on the other hand, where you have a flexion at the proximal interphalangeal joint and extension at the distal interphalangeal joint, you call this as a boutonniere's deformity. It's a French word. It's a boutonniere's deformity. Then in which conditions are these signs seen? So we see them in rheumatoid arthritis. So we have two main types. We have those that have rheumatoid factor. So we call this as seropositive. They are rheumatoid factor positive. And you have a group that have rheumatoid factor negative. So you call those as seronegative. Now the extra-articular manifestations are going to be things like intestinal pulmonary fibrosis. There's going to be things like a pleuritis, your pleural effusions, your obliterative bronchiolitis. You may have your pericardial effusions, atherosclerosis, rheumatoid vasculitis. You may have your myocarditis, your vascular or valvular rather dysfunction, specifically mitral regurgitation. You may have your anemia of chronic disease, even thrombocytopenia. Just pick any 5 of these many conditions. Very, very important. It's never really an Imed exam without a patient with a thyroid. So this woman is very famous because you saw her at 3rd year, if you were doing a lot of reading. At 4th year, you saw this woman. At 5th year, you saw this woman. At 7th year, probably you saw this woman. So a 35-year-old woman comes to your clinic complaining of impending feeling of anxiousness and palpitations. You perform a physical examination and you significantly find that there is high temperature, tachycardia, high blood pressure. Above is the facial picture of the 35-year-old woman. So describe the abnormality seen in the picture. What is the name of the lesion code? What is your most likely diagnosis? List 5 other clinical features that may present in this patient. List your diagnostic investigation you would order. So this woman here has what is known as a wide-eyed stare gaze. I showed you a picture of this earlier on. She also has periorbital edema, so there's some swelling around her eyes. She's also appearing to be a bit sweaty. If you look very closely, she's a bit sweaty. The upper eyelid has been retracted. You can see the sclera above here, so it's upper eyelid retraction. So this is probably exophthalmos. This is associated with hyperthyroidism, most likely Graves' disease. Remember the triad that we get in Graves' disease? We're going to be getting a goiter. We're going to be getting your pretibial myxedema. We're going to be getting your exophthalmos. That's your triad, the 3 things that are going to be seen in Graves' disease. Then the 5 clinical features, you may have your fine tremors, your sweating, so just features of hyperthyroidism. Your menstrual irregularities, because she's female. We do not want to see this if it's a male. Please do not write menstrual irregularities if it's a male. Infertility, your excessive weight loss, despite them having a high appetite. Your loose stool, we want to call it hyperdefecation. We don't want to call it diarrhea. Insomnia, your hair loss, and of course your pretibial myxedema. And of course investigations you want to order, your thyroid function tests, your T3, T4, TSH. You should be able to distinguish between primary hyperthyroidism, meaning that the problem is within the thyroid gland, or secondary hyperthyroidism, meaning that the problem is most likely outside the thyroid gland, most likely in the pituitary gland. Also, you order for some antibodies like your serum TSH-like antibodies, your antithyroid peroxidase antibody. You can also order for an ultrasound to check whether it's a cyst or a solid, fine needle aspiration, and cytology to check whether it's benign or malignant. So here's the last station on the ECG, and just to quickly run through you with this ECG, the findings that we're going to be seeing here, we have a normal cardiac axis. The rate is normal, so it's 16 small squares, so it's about 94 beats per minute. The rhythm is regular in lead 2. There are no significantly discernible waves that we can see in lead AVF. So in AVF, we can't even discern any proper waves here. We can't even find the P waves here. Okay, so the normal parameters that we see, the P wave, the amplitude should be less than 3 millivolts in lead 2, negative in lead AVR, and should be less than 1 millivolt in the terminal negative, with terminal negative deflection in lead V1. The PR interval is between 120 milliseconds to 200 milliseconds. Then the QRS interval is about less than 0.12. So less than between 1 to 3 small boxes for the QRS complex. For the PR interval, it's between 3 to 5 small boxes. And of course, indications for this test, of course, to diagnose an old or even a new myocardial infarction, is used for cardiac conduction abnormalities or pretty much with dysrhythmias. It's used to determine hypertrophy of the chambers. It's used in the diagnosis of ischemic heart disease. It's used in the diagnosis of pericarditis, myocarditis, electrolyte imbalances, and even some pacemaker dysfunction. So I want you to leave this last one up to you. It's just a bonus question that I want you to answer and comment in the comment below if I manage to post the recording of this live stream. And so this is what condition is in the picture, what symptom does this patient present with, what are the risk factors, what are the complications. So just leave your comments after I post the stream, and I really hope that you really enjoy this stream. So some closing remarks before I go as you prepare for your exam on Thursday or whenever it is you're writing your exam. Please, whenever you're in an Osce station, breathe. That's the first thing I want you to do. Breathe. First, breathe, calm yourself down. If you're anxious, you're not going to remember everything that we've discussed here. If you're anxious, you're not going to think through things in a logical manner. So breathe, read the entire question first and have a gist of what the examiner is expecting you to know. Then start answering them quickly. But of course, time yourself. Keep in mind that you only have 6 minutes. So this is why now I always have a schematic. If I have a history question or examination question, I know that I'm going to answer it in a particular way. So keep that in mind. I've discussed that throughout this entire live stream, and I hope you really learned a lot. And I hope you enjoyed going through all the stations in internal medicine. And by now you should feel a bit comfortable to actually take your Osce exam. So thank you for actually making it through the end of this live stream. If you survived to the end, thank you very much. Don't forget to drop a like. If you're not yet subscribed to the channel, please subscribe to the channel. Share it to a friend. Share it to a family, even share it to an enemy. God bless you, and I wish you all the best in your exam to Zambia and beyond. My name is Dr. Moses Kazevu. Bye-bye.